Okay, good morning everyone. So hopefully we have joined, most of the batches are here. I hope all of you are here. So today we are going to start the final. Yes, good morning. Allahabad is joining. Allahabad, Kolhapur is also good morning there. And rest of the batches I believe are also joining. Bilaspur is nice. Good morning Bilaspur, Belgaum. Volume is a bit low. Kota, very good morning. Very good morning to you too, Kota. So Gulbarga is also joining. Good morning Shimla, Belgaum, Karamsad. Belgaum is having no voice. Karamsad is saying good. Ludhiana, good morning ji. Good morning Ludhiana. That's great. So we have joined. Agroha is also good morning. So most of us have joined, I believe. Karamsad, good morning. Good morning, Karamsad. Yes, they are saying that yes, there is a problem. Some volume. Okay, we'll do with that. Okay, so today is hopefully we believe you also agree with me that this should be the last class of community medicine because it's been extended so long. But I hope with this subject, you know that it's been so lengthy subject. These much is required. So now let us start with today's discussion. Today we'll have one discussion paper also. So I request most of the coordinators of different batches that this should be there should be this availability of having discussion paper, because after 2 hours we'll be starting a discussion paper so that the overall coverage of the entire community medicine should be done. So I request all the coordinators of different batches that or different centers that they should also distribute the discussion paper. Agra is having no audio, so we would like to go with this, that so that you should have audio. If there is an audio problem, that should be rectified. Okay, now let us start with the communicable diseases today, and after that we'll be taking communicable diseases today, and after that we'll be taking the yes, Jabalpur is saying yes. No volume. Yes, we are rectifying that. Their volume problem. We don't have discussion paper. Ludhiana. Yes. The discussion paper will be given to you by your coordinators, because that will help in getting the proper coverage of the entire system. Even we don't have Karamsad. Karamsad is also saying yes, you will get it now. We didn't get the discussion paper. Belgaum also don't have discussion paper. Discussion papers are not with the batches, so we also don't have. Okay, Agroha is also not having any discussion paper. Anyway, don't worry, beta. Don't worry. If Shimla is also not having that, no coordinator saying no paper. Ludhiana, Vishakhapatnam V2. Okay, so that paper is not sent, I believe. I'll ask here after this 2 hour. We'll ask it. Okay. Otherwise, we'll do it in a different way. Don't worry. Okay, I know what is there in that question paper, and I'll let you know all those things which are important. And okay, I got it. No batches having the discussion paper, that may get missed. Anyway, no issues. Now let us start with the communicable diseases first, and that will cover the entire things. Now first of all, the question which is asked there is, now one ground rule we'll make today, because this is the last class and you'll be having the radiology class thereafter, that the discussions will be done at the end of the session. And what we'll do is we keep on going through this communicable disease portion at one stretch, and at 11:30 we'll have one break for small for having a tea break. Okay, so at 11:30 we'll be having a tea break. Okay, now there are very few questions which are asked in entrance exam, and AIMS asked a very important thing, that father of public health. And you all know, when it comes to father of public health, it is actually cholera. So father of public health is cholera. So very first question which is asked is father of public health, which is cholera. Now Slim's disease, we all know. Slim's disease is HIV, AIDS. But side by side, you should also know what is White's disease. And whenever there is White's disease, always remember White's disease is actually tuberculosis. So if it is White's, it is tuberculosis. But if it is Slim's, it would be what we call as HIV. Then there is Black Death. You all know, if there is Black Death, this is plague. But those who have you've started going through your guides, you must be getting a question which is known as black vomitus. Black vomitus. And if this is a question that what is a black vomitus, always remember black vomitus is yellow fever. So yellow fever is black vomitus, but if it is black death, it is plague. Then you may have fifth day disease. Fifth day disease. If it is fifth day disease, this would be trench fever. So fifth day disease is trench fever. Fifth day, trench fever. Then you also have eighth day disease, and you know, most of us know eighth day disease. Eighth day disease is tetanus. Tetanus neonatorum. So tetanus neonatorum is eighth day disease. Then you also have heard about the 100-day disease. 100-day disease. And when there is 100-day disease, it is pertussis. 100-day disease is pertussis. And third day disease is rubella. So these are very many questions which are asked in entrance exam, that what is black vomitus, fifth day, eighth day, 100 day, third day, all these kind of questions are there in entrance exam. Now let us start with the diseases now. These were those questions which were compiled, and these were asked in different entrance examinations. Now let us come to those questions which are coming from the specific diseases. As you will all agree with me that communicable disease is a vast chapter, and it will take huge time to cover it up. So what we should do is we should be very specific on the points which are asked from communicable diseases and which are not covered actually in your either medicine classes or pediatrics classes. So now let us take first disease, which is smallpox. And the very first question which is asked in smallpox was that they once asked that smallpox last case was detected from which country, and you all know that the last case was detected from Somalia. So the last case of smallpox was detected from Somalia. Then they ask a very relevant question. Yes, very good, Kolhapur. That what is actually the last case of smallpox in India? So always remember, in India it was detected in 24th May 1975. So 24th May 1975, the last case, 1975, last case of smallpox was detected, and that was detected somewhere in West Bengal, and but later on it was found that it was an imported case from Bangladesh. So there is a question that India was declared smallpox free. Okay, Allahabad, I'll tell you. In India, it was in 24th May 1975. 24th May 1975, the last case of smallpox was detected from India. But to be very true, this was not from India, this was from Bangladesh. So there was a question that India was declared smallpox free in which year? And always remember, India was declared smallpox free in 1977. So in 1977, very good, April 1977. Now you can understand that how can it be possible that in 1975 we have a case and in 1977 we were declared free. So in 1977 we were, and even the eradication was confirmed. Eradication was confirmed. So eradication status was given, and that was given that it is this. Okay, then there was a question that can you tell us that which vaccine is live but not attenuated? We have already heard that. So the vaccine, yes. So there is a great problem of audio. Agra, please have a look. Yes, I have asked the coordinators that they should look that there is a problem with the audio system. Now they are working with that. Okay, Agra, don't worry. They'll have this and they'll try to rectify this problem now. Okay, so that was there. That now a very important question which is very important, and that is very important question. Smallpox has highest potential of being used as biological as biological warfare. There is a bit confusion, bacho. There is always a confusion when it comes to yes, when there is a question, when there is a problem with this question, when they ask you one very important concept, and they ask you that the maximum mortality is in which disease, and then they ask you three options: plague, then they ask you smallpox and anthrax. Then always remember that anthrax can have the maximum, mortalities if it comes, because respiratory route is there, and secondly the mortality is very much. But when it comes that which has got the highest potential of being used as biological warfare, Agra has got the problem. Yes, yes. Dear Agra students, don't worry, don't get anxious. We are in communication with your coordinators. Okay, Agra. They are asking our coordinator is asking Agra people that kindly check their local audio system, because from here there is no problem. Okay, so that is very important here. Okay. Okay, so smallpox has, as I told you earlier, that smallpox has highest potential. Why? Because you understand, when we come to this problem of terrorism, always remember, terrorism means to kill few. Yes, to kill Belgaum, maximum mortality. Yes, if maximum mortality is there, it will be a tie between plague and this anthrax. And always remember, but that in anthrax there is a problem that yes, Allahabad botulism, if it is an option, I am saying if three are the options, and three options are: number one plague, number two smallpox, and number three is anthrax, then anthrax will kill. But if suppose they say the maximum potential would be of smallpox. Why? Because after 1978 nobody is vaccinated. So if it kills people, it will kill specifically the youth, and that is what terrorism addresses. It will specifically kill the a productive age group, and what it will make, it will worsen the situation. So that is there. Agra, you didn't miss anything. That was just a smallpox brief that in 1978 it was there. Okay, so that is there. Gulbarga is also saying the repeat mortality maximum. Okay, I told you beta that if three options, in most of the time, most of the questions, you have three options in your entrance exam, and that is plague, smallpox and anthrax. Then you tick anthrax. As he was saying, botulism can be there, but botulism spreads in lesser way in comparison to this problem of anthrax or plague. The way by which anthrax spreads, it spreads through the respiratory route, and so it will spread very fast. That is why the mortality will be more there. But if suppose the question is asked that it is which has got the highest potential, then the potential highest will be of smallpox. Okay, now let us come to the second disease, because as I told you earlier that smallpox is eradicated, and there was a question that smallpox was eradicated because of which reason, and you all know that the reasons are: there was a very effective vaccine which is available. The second is that there is the international cooperation which was there, and there was no extra human reservoir available. So no extra human reservoir, very high level of international cooperation, and very effective vaccine, and the incubation period is very small, and the natural history of the disease is known. So it's not that important. You can do it by your general knowledge also. Now let us come to the different disease, and that is chickenpox. Now what are the questions on chickenpox? Number one, the incubation period. Incubation period of chickenpox is 7 to 21 days. Commonly if they ask you, it is 14 to 16 days. So 14 to 16 days is the commonly asked question, and that is 14 to 16 days. Okay, year of eradication 1978. 1978 it was eradicated, Belgaum. Okay, then there was a question, and then they ask you a very important concept, that incubation period is 7 to 21, commonly 14 to 16 days. Then about rashes, and we all know the characteristic of rashes are pleomorphic. Then they ask you that the distribution is centripetal. And a very important thing that which they ask you is that all stages non-infectious, all stages are non-infectious except vesicles. All stages are not infectious except vesicles. So that is also a very important concept which you should know, that in this case rashes are non-infectious. So either these are scabs or these are anything, crust, scabs, Vishakhapatnam, no, that's centripetal. Yes, there is a confusion in some of the books which they have written Vishakhapatnam. Kindly get it corrected that these are the centripetal distribution of rashes. In few books it's written centrifugal, but centripetal. Then there is a very important question which they ask, and that is when they say about chicken pox, and that is about the non-umbilicated rashes. Non-umbilicated. So non-umbilicated rashes, centripetal, and that is as we told you earlier that here the palms and soles are unaffected. Palms and soles are not affected. And then axilla spared. So these are some of the things which you should remember about the chicken pox. Then they say that after rashes, after fever, how many hours after fever rashes emerge? And we all know within 24 to 48 hours after fever, rashes appears. So it is very, it's very communicable also. And then they say that for control, what should be done? And we know for control, isolation required. Isolation required. The question is asked, isolation of the case required 6 days after onset of rashes. Six days after onset of rashes, isolation of case required. Then they say, yes, chickenpox vaccine. And we know that now chickenpox vaccine, OKA vaccine, and earlier version says, earlier when there was the previous questions in your guides, if they come from the previous guides in 2006, 7, 8, 9, 10, isolation for how many days? 6 days after onset of rashes. That is I'm saying till 6 days after onset of rashes, dear Mysore, till 6 days after onset of rashes. That is what is being told, that whenever you find that a patient is there, then rashes, 6 days after onset of rashes, you should get him isolated. Then that is very important, that in earlier version we say that in earlier version we say, sir, does monkeypox virus infection gives cross immunity to smallpox? Yes, it is said, but actually this was more, because that is why we smallpox vaccine was not meant for smallpox. Actually it was a monkeypox vaccine. So that is true, Belgaum. Okay, so earlier there was a question, no, we were somewhere. Yes, earlier there was a question that for this less than 2 years it is contraindicated, and 2 to 12 years 1 dose required, and more than 12 years 2 doses required. So that was one of the things, that less than 2 years contraindicated, 2 to 12 years 1 dose, more than 12 years 2 doses of vaccine required. But you may have this kind of question now, that nowadays what IAP is saying, as per IAP, now what they are saying is, because this was earlier version, you may ask me that why are you telling all these things, because as I told you, sometimes only the earlier guides questions are asked or they are repeated. But if they say as per Indian Academy of Pediatrics, now they say all children should get 2 doses of varicella vaccine. So what they are saying is that the first vaccine should be given before that is at 16 to 24 months, and then after what the new guideline is saying, that at 16 to 24 months give one varicella vaccine, and the second vaccine or second varicella vaccine should be given at 5 years of age or 5 to 6 years of age. So that is something which they are saying. They are saying for every child at least 2 varicella vaccine should be given. So you can have both kind of questions in your entrance exam. Okay, now let us come in case of adults. Yes, in case of adults also, Mysore, that's what we have told you earlier also, that even if you require or I require, if I am working in a hospital, then 2 doses of varicella vaccine is required with a minimum gap of 1 month. So with a minimum gap of 1 month, at least 2 doses of varicella vaccine required. So then there is a question on next very important disease, and that is very many time asked, and that is Bilaspur. Yes, beta. That's what I told you. That now they are saying, because earlier we were saying that before 2 years of age, no varicella vaccine should be given. It was contraindicated. But now they are saying no. After 1.5 years of age, you can give and you should give one varicella vaccine, and the second dose should be given after 5 years of age. Okay. Allahabad, yes, they are asking about, it's more than 85%. Allahabad, the secondary attack rate, it's very high, and you all understand, you have seen it. When there is a case of chickenpox in your hostel, you must have seen it spread like anything in the hostel. Okay, now we come to the different disease, and that is measles. Now let us talk about measles. But as we asked earlier also, let us first do all the questions, and if there are your queries, we'll take it at the end. So measles, the first question with the measles is that its incubation period, and if incubation period of measles is asked, first of all you should say average incubation period is 10 days. Average. If suppose second question is asked that what is the average incubation period in case of vaccine, it should be 7 days. Average for vaccine. So for vaccine it is average 7 days. For disease it is 10 days. And 10 days means fever. 10 days means fever. So from the receipt of infection to the day when fever happens, when the patient develops fever, it is 10 days. Sometimes they ask you that in case of disease, it can also be 14 days if it is for rashes. So these 3 things we always know, that incubation period in case of disease is 10, for vaccine it is 7, and for the rashes it is 14 days. Now what is the question? The question is asked, vaccine should be given, that is why vaccine should be given post exposure. Vaccine should be given post exposure to susceptible. Vaccine should be given to post exposure to susceptibles. Vaccine within 3 days of contact. Now I believe you can understand. So this is also a very important thing, that vaccine should be given post exposure to susceptibles within 3 days of contact, and that is very important, which we already know. Then there is a question, and the question says that, now we are coming to some controversial questions, that which is the most common complication after measles, and it should be diarrhea. Please don't write otitis media. It should be 1, it should be 2. Because in most of the books it is written otitis, in some of the books, not most of the books, in some of the books it is written, some of the books of microbiology even states that otitis media or is the most common complication. So please don't look at those, Then most common complication is diarrhea. Then they say life threatening or serious complication. Most common serious complication or life threatening complication is very good, pneumonia. And then they say somebody has written that SSP, that is actually least but threatening. So least is which we call it as SSPE, but this is least common. Then they may ask you that infectivity of measles. Infectivity of measles. And when there is infectivity of measles, then always remember it is very important. 4 days before to 5 days after. 4 days before to 5 days after appearance of rash. Aligarh, you didn't lose anything. It was just smallpox, chickenpox. We have come to measles beta only. So don't worry, Aligarh. So 4 days before to 5 days after appearance of rashes are the infectivity of measles. Sir, is post-exposure prophylaxis useful for chickenpox? People say that yes, you can give chickenpox post-exposure prophylaxis also to the susceptibles, but along with that, they say that acyclovir should also be given. Vishakhapatnam. So it is not very useful. People say that because we as a doctors have this feeling because the incubation period is very small, and if a person or a student is in contact with somebody who has the disease chickenpox, then yes. Because adult will need 2 doses, 1 month gap. So effectively or practically you can understand it's not of much use, but yes, acyclovir can be given. Yes, Bilaspur is saying this is saying a very logical thing, that we should have all these queries at the end. We agree. Chalo. Then there is a question again, and that is 95%, very important, 95% herd immunity required for elimination. This is very important, which you should know. Why? I'll tell you. The first one is 95% herd immunity is required to eliminate measles, while we always say that when 60% herd immunity is required for prevention of outbreak. So these are 2 different things. That is why we should write them side by side. 95% herd immunity is required for elimination of measles. So 60% herd immunity is required for prevention of outbreak. You may also call it as 40% or more than equal to 40% herd immunity. No, more for 40% susceptibles will cause outbreak. So we may also call it this way, because these are both the languages which are there in your entrance exam. First is 95% herd immunity required to eliminate the disease. 60% herd immunity is required for prevention of outbreak, and the same thing, second and third are the same thing. More than 40% susceptibles are required for having an outbreak. Then there is a question that case fatality rate, CFR, here is 2% to 15%. So case fatality or CFR is 2% to 4%, which is very important. Then very important part which they ask is regarding, yes, last thing, and which they ask that the rashes are characteristically seen in post-auricular line. So rashes are characteristically seen in post-auricular spread to trunk, extremities, and disappear in the same order in which they appear. Okay, so that is important for measles. We also know that in measles we have the when we say for measles we have this complex spots which are seen in cases when we say complex. These are seen in here for second upper molar. Second upper molar. So that is something which is important for measles. But always remember, as I told you earlier also, that if there is a classical triad of symptoms for measles, it is always catarrhal symptoms which you should include. Catarrhal symptoms. The second one is fever, or the first one is fever, second one is rashes, and third one is catarrhal symptoms. So whenever these are there, complex spots before or after rashes, these are complex spots are usually with rashes, when rashes are erupting, but if suppose this is a question which they ask you after or before, then after is a better option. Okay, but yes, these are during those days only when the rashes are there. These are usually complex spots which are seen. Okay, now there is a question. Now this measles is over, and most of the time the questions are from the vaccination strategy which we have followed, which we already know that there are now 2 doses of a measles vaccine which is under national immunization schedule, and that that is very important for us to understand that measles elimination campaign is going on, and in MEC 2 doses must, and in all those states which have got less than 80%, as I told you earlier, that in those states, where the routine immunization of measles is less than 80%, second dose of measles vaccine is to be given till 10 years of age. So any child who is 10 years of age should be given second dose of measles vaccine, but it is all those states which are having routine immunization for measles less than 80%. So that is very important for us to understand. So now it's a huge coverage and a huge national health program for measles elimination is going on. Let us take the third disease, and that is rubella. Now the question which is asked, very important for rubella, is infectivity. And always remember, it is highly infectious. Infectivity. And infectivity of rubella is maximum when rashes erupts. Infectivity of rubella is maximum. If more than 80%, then how many doses? 1 or 2? Again, as I told you, Karam sir, that 2 is ensured everywhere. But in cases of routine immunization, if it is more than 80%, then what we say that the second dose should be given through routine immunization only. So 2 doses everywhere, but for less than 80% till 10 years of age. And in all those states where it is more than 80% coverage, it should be given through routine immunization only. Okay, then the question, as I told you earlier, that it is infectivity is maximum when rashes erupts, and here the second very important question in rubella is There is no carrier stage here. No carriers seen. Third stage, which is very important, and that is second attack rate for measles. Second attack rate for measles, Mysore, it is more than 85%, and it is again more than 85% for measles. These are very close to each other. That is why these kind of questions are asked, which has got the maximum second attack rate. And Mysore, so it is for this also, it's very high. Okay, so I've asked them that they should look for notepad. Somewhere notepad is missing. So that is third, which is very important, and it is very, very important question for all India exam, that in India, notepad, yes, we are going to that. In India, no. Yes. Now the question says, in India, more than 40% women, more than 40% women of age bearing, more than, notepad again is not working. अरे यार कुछ हुआ, हिल गया. Notepad, quota, yes, quota, we are trying to rectify this problem. Now let us come India. More than 40% women of childbearing age are susceptible for rubella. This is a very important question. In India, more than 40% women of childbearing age are susceptible for rubella infection. Then what is the strategy which is being followed by Government of India? The strategy, it is very important. Strategy by Government of India for prevention of rubella is, number one, immunize women, and that too non-pregnant women, immunize non-pregnant women of childbearing age. So that is 15 to 39 years of age. So they say, first of all, immunize all non-pregnant women 15 to 39 years of age. Number two, interrupt transmission 1 to 14 years of children. So first is, one has to interrupt transmission in 1 to 40. No, Bilaspur, it's not 45, it's just 39. In this guideline, rubella, they say 15 to 39 years of age of women should be vaccinated first. Then 1 to 14 years of children, interrupt transmission in them. And third one is incorporate it in routine immunization. Incorporate in routine immunization. So these are the three strategies which are being followed. Those students who are from Tamil Nadu state, they know that the first step is being done. The second, they are doing it very religiously. Now it is an adolescent girls, all schools of adolescent girls are being covered very fast in Tamil Nadu because they are doing very well in health system. So, and the third one is incorporate it in routine immunization. Like Delhi has already incorporated MMR, measles, mumps, rubella in their routine immunization. Now the question is asked that what are the problems if a woman gets infected during pregnancy with rubella? You must have heard about rubella parties, and those rubella parties which were thrown in Germany or around nations, you already know they are there. Okay, so what is that? The question is there that if it is first trimester, if infection is in first trimester, the outcome is, if it is in first trimester, outcome is spontaneous abortions. Okay, there is a problem with the Allahabad this system. but again I'll write first trimester. First trimester. If it is first trimester, spontaneous abortions. Apart with that, there can be the very important thing. If spontaneous abortion do not occur, child is born, the child will be born with congenital rubella syndrome, CRS, congenital rubella syndrome. And this congenital rubella syndrome is having three things: PDA, then congenital cataract, and congenital deafness. So PDA, congenital cataract, congenital deafness, these are the very important thing which you should know occur if there is no spontaneous abortion. So you can understand very well that if a woman gets infection during her first trimester, it is indication for abortion, indication for MTP. So if it is confirmed that this lady got infected during her first trimester, it is better to go for MTP. Then there is second trimester. If there is second trimester problem, then always remember in second trimester the problem is of congenital deafness. So in second trimester, congenital deafness alone occurs. And if it is third trimester, then there is a problem of third trimester. There is a problem which we say as no major congenital anomaly. No major congenital anomaly occur. So if non-specific question is asked and they may ask you that can you please tell us if there is a woman who get infection during her pregnancy, what is the most common congenital anomaly, you should always remember non-specific question. So non-specific question, most common congenital anomaly if pregnant woman got infected with rubella, always say it is congenital deafness. Because now we know, because congenital deafness occurs in first trimester as well as in second trimester. But in third trimester it do not occur. Means if a child got if the pregnant woman got infection during third trimester. So this doesn't occur in third trimester, congenital deafness. But as it occurs in first as well as second, so it is the most common congenital anomaly. Now then they ask you again another very important question, and there is a huge controversy which was going on even in the Facebook, and that is sensorineural deafness. Then they ask this very important question, which is if vaccine is given after how many days of vaccine pregnancy can be planned. So new guideline says yes, very good. New guideline says 28 days or 1 month, while old guideline says 3 months. So you may ask me, yes, minimum 1 month, yes, that is very true. So old one is saying 3 months and new one is saying 1 month or 28 days. So it's always better to choose this one. This is an old concept and it's still given in your PARC. So that may create some of the problems which are there, and students are getting questions with this. Now the third disease which is important, or the next in the order, is mumps. There are very less questions from mumps because mumps as a disease do not have very much things. It's a viral disease. You all should understand one thing as a clinician, that all these diseases are viral disease. If your patient as a child is well fed, then all these diseases go unnoticed. But if the child is malnourished or having a less immunity, then only symptoms aggravate and things happen wrongly. That is why you should have you would have been told by your clinicians, even in community medicine or medicine, that if it is a viral disease, always tell your patient that if you take treatment for 1 week, it will go. If you do not take treatment for 7 days, still it will go. So it's the same thing, that whether you take treatment for 1 week or you do not take treatment for 7 days, you are going to get well soon. So what is mumps? Mumps is again a viral disease, and it is a single serover disease. Single serover. Again, it is RNA myxovirus. The question which is asked, as I told you, very less questions are asked. Again, 86% secondary attack rate. So one attack is giving lifelong immunity. Lifelong immunity. One attack is giving lifelong immunity. That is also very important. And most common complication. Again, a very controversial thing. In some of the books, it is written parotitis. It is not. So what exactly is the most common complication? It is orchitis. So most common complication is orchitis, but we are not calling it as most common because it usually occurs in adults. So you may be asked that in children, aseptic meningitis. So meningitis is there. Yes, Jammu, very true. Measles is also single serover disease. Measles is, yes, you can say, because in measles also, when there is an attack, there is a safety. Okay, so in children, aseptic meningitis occur. But you may be asked one question, and that is overall complication. Yes, Allahabad is asking that question. If it is overall most common complication, then overall most common complication again is orchitis. So most common overall complication again is orchitis. As I told you that in children, it usually go unnoticed. In children, it usually go unnoticed. So nobody notices. But if it is asked that which is the most common overall, then you should say this. Mysore is asking before or after parotitis. What is this? HIHMS. What is this they have written? I'm not able to read it. Mysore. Okay. Mysore is saying orchitis before or after parotitis. As I told you, parotitis is just a symptom, beta. Mysore. Try to understand. Parotitis is very common. It is very common. It is not the complication. Rather, you should say it is a symptom. And if it is not there, even a clinician is not able to understand whether a patient is having parotitis or mumps or not. So it's more a kind of thing. Okay. Now, is most common. Yes, no. Most common. No, Allahabad. No, please. It's the orchitis which is the most common. Okay. Nine. Mic problem. Kolhapur. There is a problem with mic. Kolhapur. Yes. So I told you. So they are looking for that. Okay, so mumps is already done. So not very much things in mumps. Okay. Now let us come to another disease. As I told you that we'll take specifically community medicine questions first because they are very important. Okay, then there is the disease which is diphtheria. And as you know, diphtheria, most of the questions are from your microbiology section. When they ask you regarding the colony characteristics, the strain characteristics, then what are the questions in community medicine? Yes, number one, 70% or more herd immunity prevents outbreak. So it is outbreak. Again, the problem of notepad. So they are getting it corrected. Notepad is not corrected, so they are making it. So more than 70% herd immunity is required. So if suppose very important question from diphtheria is more than 70% herd immunity is required to prevent outbreak. The second very important question is that in diphtheria a special type of carrier is required which is known as pseudocarrier. Pseudocarrier. And what is pseudocarrier? We already have discussed. Pseudocarrier means when or pseudocarrier. Sometimes it is also known as paradoxical carrier. Paradoxical carrier. It's not pseudo. No, it's not. Sorry. Make a change. Pseudo carrier is seen in diphtheria, and we have already know paradoxical. Don't write here. Paradoxical carrier is actually seen in cases of typhoid. So please make a necessary correction. Pseudo carrier is seen in cases of diphtheria. So pseudo carrier is seen in cases of diphtheria. What is pseudo carrier? We already know that pseudo carrier means carrier of a virulent strain. So if a question is asked, what do you understand by pseudo carrier? Pseudo carrier means when a person is a carrier of a virulent strain, then it is known as pseudo carrier. It is a characteristic of diphtheria. All are not pseudo carriers. There are carriers also, but pseudo carriers are also shown to be there in cases of diphtheria. But if somebody asks you what is paradoxical carrier means when there is one carrier and it spread infection to another carrier, and carrier from a carrier, as I believe we have discussed it earlier also. Yes, infection from a carrier. So carrier to carrier, that is something which was there in typhoid. Anyway, pseudomembrane we already know. It is a concept which you have heard or which you have discussed in your medicine classes or pediatrics classes or pathology classes also, that there is a characteristic pseudomembrane which is seen in cases of diphtheria. Then they say mode of transmission, very important. It is very important for diphtheria, bacho. Do remember. They say mode of transmission in diphtheria, MOT. MOT or mode of transmission is in two ways. Number one is air route and the other one is non-air route. Air route and non-air route. And air route, as we already know, respiratory, and it can be direct, it can be indirect. Direct and indirect are the two routes of respiration. But if they say what is a non-air route of mode of transmission of this disease, always remember it is through milk. Milk. Infected skin. Conjunctiva. Wounds. So this is very important. Yes, respiratory route is there always, that is remember, but that is different from wounds, cuts, conjunctiva, okay, contaminated milk. All these are again a very important way by which diphtheria spreads. Then how do we control? Control of diphtheria. Then always remember, control of diphtheria is to be done in three. Control in cases, control in carrier, and control in contacts. So you may have question from these three sections, that how you will control diphtheria in cases, in carrier, and in contacts. In cases, drug of choice is very important. Penicillin. Here drug of choice is erythromycin. And here when they say what is there in contacts, again right here it's a long thing. If contacts have booster, if contacts have booster in last 2 years, nothing required. So if contacts have booster in last 2 years, nothing is required. But if booster more than 2 years, single DT required. Single, capital D, capital T. So if booster is more than 2 years, if the child is having booster for more than 2 years, then single DT required. If the child has booster for less than 2 years, nothing required. And for non-immunized contact, non-immunized contact, for non-immunized contact, actually penicillin injection should be given. penicillin or erythromycin. So penicillin or erythromycin can be given. So these are the two things. So this is very important question which is asked, and if you go by your guides, they will ask you that contact have booster 2 years back, contact do not have booster 2 year back, or it was an unimmunized contact. Now the second very important question which you know all about is the Schick test, and we know in diphtheria Schick test is important because the interpretation is a bit different from rest of the dermatological test, and Schick test is also known as susceptibility test. Schick test is susceptibility test for diphtheria. Yes. So we are not going to repeat it, as you know. The only thing which you should remember is positive Schick means susceptible and negative means immune. So that is all what we require, because in most of the places when we say derma tests and when we say it's a positive test, we interpret it as immune. So Schick test is a bit different. The interpretation is different, and when we say it is positive, we should say that actually it means susceptibility. Now let us come to another question, and that is pertussis. The second disease is pertussis. When it is there, as we have already call it as, it is 100-day disease. Okay. Then it is the question which is asked is that it produces, you already know in microbiology that it produces both exotoxins and endotoxins. And it has got very well documented second attack rate. Now this is very important, second. So I've told you second, not the secondary. So that means re-attack on the same individual. So when I'm saying pertussis is known because of this reason also, because it has got a very well documented second attack rate, which is very important. Cannot be eliminated with present vaccine. Cannot be eliminated with present vaccine because, why? Because maximum seroconversion is 80% only. Maximum seroconversion is 80% only. So it is very difficult to eliminate this disease with the present vaccine. Then they ask you, yes, source of infection is a case. So source of infection iska case hi hai, because we say that no carriers. We also say very important thing, and that is that subclinical cases do not occur here also. So no subclinical cases. Then a very important thing which they ask, control. So control of the disease is by erythromycin. And that, as we have as I told you earlier in the before question of diphtheria, that if it is control in case and control in contact, the answer would be same. In both the things, erythromycin should be given. So control in case as well as contact again will be same. Now the next disease. And the disease which we are going to study now is very important for you because of so many reasons. And one reason is that now we are a polio free India. So date of polio free India. So I hope most of you have remembered what is the date at which we were announced polio free by government of India, because it is recent only. Yes, that is very true. It is 27th March 2014. Government of India declared. Yes, it declares us. It was by WHO only, Vishakhapatnam. It's the same thing. There's no, very much catch when it comes to all these kind of questions. You should remember that we were declared on this as on 27th March 2014. It was WHO certificate is given. Okay, then there is a question that P1 causes epidemics, P2 most antigenic, and most easily controlled. P1 is causing most epidemics, P2 most antigenic and most easily controlled, and P3 is most common cause of VAP, vaccine associated paralytic poliomyelitis. So P3 is most common cause of VAP, vaccine associated paralytic poliomyelitis, and it is 1 per 1 million vaccinees. 1 per 1 million vaccine is what we know all about. The second, which is very important for you to remember about polio, is that recently in Maharashtra, VAP in 2013 was seen, and that was due to P2. So that is an important observation, and that should be known to us because it's a tentative or a very potential question for your entrance exam. Though we say that P3 is most commonly causing VAP, but if somebody asks you that recent most or the newest case which we have seen in India in Mumbai was due to which strain, it was by P2. As we know that polio is one disease which we say as is the best example of tip of iceberg phenomena. So always remember, polio is of two types. One is apparent and he's saying is VAP communicable? Vaccine associated paralytic poliomyelitis is communicable. देखिए, because this is again a virus, okay, so it has to be, yes, but we have not seen yet any case where one VAP also causes another VAP, but yes, it should be, so it is apparent and non-apparent. Apparent is 95%. And non-apparent is actually less than 5%. It is, we should say, more than equal to 95% is, sorry, I have written wrong this way. Non-apparent is more than equal to 95% and apparent is less than 5% only. Non-apparent, apparent. Now this 5% is actually divided into two. One is known as what we call as, or rather 3 is abortive polio. Abortive. It is also known as flu-like polio. flu-like. The second one is known as meningitic type. Meningitic type. So second one is meningitic type, first is abortive, and the third one is also known as paralytic. Now these two together make 2 to 5%, and less than 2% actually is paralytic. Now this paralytic again is divided into 3, and it is known as spinal polio, bulbar polio, spinal, bulbar, and bulbospinal. Spinal polio, bulbar polio, and bulbospinal polio. Bulbospinal, spinal, bulbar, bulbospinal, and this is the most common type. So now we can understand very well is that there is a question in entrance exam, and they say that with one case of polio, with one case of paralytic polio, there are around 200 subclinical cases in community. So with one case of paralytic polio, there are around 200 subclinical cases in community. This is very many time asked question in your entrance exam, and as I told you, because that is not given to you, those questions sheets, because that is being provided to you, maybe they'll provide you later, and all these type of questions are there in entrance test. Okay, no issues, you'll get it later. Then the second is the question which they ask is that if suppose we say it is for one case of paralytic polio, but if they say one case or one case of polio, you remember polio only, not paralytic, one case of polio, it can be, you know, this aseptic meningitic type. You remember sometimes in your entrance exam or sometimes in your viva, teachers do ask you that if suppose you have to go for a survey for detecting polio cases, what are the 2 body samples which you will take, body fluids? You will say first we'll take the stool samples, and the second, if time permits, we'll also try to take the throat swab. So this throat swab is actually for detecting abortive polio, because abortive polio is flu-like polio. So one case of polio, there are around 1000 subclinical cases in children. With one case of polio, it's not paralytic, there is 1000 subclinical cases in children and 75 subclinical cases in adults. So it is again very important that if there is one case of polio, there are around 1000 subclinical cases in children and 75 in adults. So students have learned it. If suppose this is an elaborative question, they say we'll answer it this way. If they say it's a small question, that where they say that one case of paralytic polio is detected, how many subclinical cases do we have there in the community? We'll say it's around 200. Okay, then again, next question. They say, okay, if suppose you are going for polio, then you should have some very good polio surveillance activities. Yes, that is known as AFP surveillance. Acute flaccid paralysis surveillance. I believe we have, if we have gone through this earlier, we'll skip it because that was also discussed, I believe, during your vaccine class. But if it's not, no. Okay, AFP surveillance. It was not discussed, then we'll discuss it now. AFP says that all children less than 10 years of age all children less than 10 years of age are surveyed. Okay. Now what they say is that uh, uh, in all these children who are less than 10 years of age are surveyed for AFP. And what is AFP? We all know. AFP is having a differential diagnosis of they are saying Kolhapur. What I have written? All children less than, oh yes, less than 15 years of age. Oh yes, yes, yes. 15 years of age. Yes, this is a wrong thing. Now we should write it 15. Very nice. Yes, yes, yes. Please, please. Yes, it was my mistake. It is AFP is done in less than 15 years of children. Yes, all children less than 15 years of age. Absolutely. Kolhapur, Bilaspur, every one of you is right. So what is the differential diagnosis? The differential diagnosis is polio, then Guillain-Barré syndrome, GBS. The third one is transverse myelitis. And the fourth one is traumatic neuritis. Traumatic neuritis. And what we call these three are known as non-polio AFP. Non-polio AFP. So GBS, transverse myelitis, traumatic neuritis, all these three are known as non-polio AFP. Now what is the question in entrance exam? They say that non-polio AFP should be more than equal to 2 per 1 lakh children less than 15 years of age. Now there is a controversy here. Controversy. And the controversy is about, some of the guides are saying less than equal to 1. And a controversy is, it is less than equal to 1 or less than equal to 2. Then this is there. Because in few of the guides it is written that it is equal to, less than equal, more than equal to 1. Non-polio. It is non-polio AFP. This is very important. It is non-polio AFP which is equal to, more than equal to 2 per 1 lakh children less than 15 years of age. The second criteria is that in more than 80% of children in your reported cases, in more than 80% of reported cases, in more than 80% of the reported cases, two stool samples should be taken. These are 8 gram each, 12 to 40 24 to 48 hours apart. 24 to 48 hours apart. So 8 gram each, 24 to 48 hours. 24 to 48 hours apart. 8 gram is also known as, sometimes they call it as thumb size. Thumb size tool. So thumb size tools within 14 days. Of reported event. So there are few things which are important. I'll tell you what are those important things for your entrance exam. One is this, in more than 80% of cases. The second one is 2 stool samples. The third one is 24 to 48 hour apart. And the fourth one is within 14 days of the reported event. Then this should be done, and that is very important, which we should remember. The next question they say is that the residual paralysis survey should be done till 60th day of paralysis. 60th day. So 60th day of paralysis, residual paralysis survey should be done. But if it is for VAP, it is 30 days. So for VAP, the residual paralysis survey is done till 30th day after paralysis, and residual paralysis survey is done in this case till 60th day of paralysis. Then the question is asked, then what should be done? As we already know, we have discussed it, that this is an AFP case. As we told you earlier, it's not AFP polio, it can be AFP non-polio also. So we have already discussed that if it is an AFP polio AFP case, it can be polio or non-polio. 100 yards, there should be ring immunization. And what is ring immunization? It is all children less than 5 years of age given additional OPV drops. So additional OPV should be given to all children less than 5 years of age, 100 yards around an AFP reported case. So AFP, it is not polio. So mind it, it's not polio, it is AFP. So any AFP case, 100 yards around that AFP should be covered with an additional OPV dose. So that is the second thing. Then they say, how will you confirm? Confirmation of polio. So confirmation is, number 1, detection of wild polio virus in stools. If there is a detection of wild polio virus, this is a very, very important word. Wild polio virus in stool, then that is known as polio. Then second one is, or increase in fourfold rise. Increase in antigen antibody titer. So that is something which is important. So increase in antigen antibody titer, this is given. Allahabad is asking trivalent OPV to be given. Trivalent OP, where? This you are saying there is an AFP case against this. Always remember, in such cases this is an additional, we call it as subnational ID or SNIDs. In all these, only bivalent strain is given. So whichever is been there in that area, which is in circulation, that is given. Trivalent OPV is only for routine immunization. So this trivalent is only to be given at the time when there is 1.5, 2.5 and 3.5 month regular vaccination or routine immunization. So it is actually bivalent which is available, and now government is asking for a monovalent also. Okay. Okay, so that was from the section of polio. So there is one more question which is asked in your Karnataka PG, and that was period of communicability. Period of communicability, and that is in when we say period of communicability, it is 7 to 10 days before to 7 to 10 days after appearance of symptoms. 7 to 10 days before to 7 to 10 days after appearance of symptoms. And if somebody asks you what is the incubation period, it is 3 to 35 days. It is 3 to 35 days. Residual paralysis VAP Aligarh, it is 30 days only beta. 30. So IP is 3 to 35 days in cases of incubation period for polio, and it is actually, usually we say, it is 7 to 14 days. So if you say about the range is 7 to, the range is 3 to 35 days. It's a huge range, but yes, what we generally have is that within 7 to 14 days. That is why we are saying that within 14 days of paralysis, the survey, the collection of, all these collection of stools should be done religiously, and that is very important. Okay, then there is a question, and then the question is on next disease, and that is hepatitis. Yes, Karam, so this is very true. Okay, now we come to the questions on hepatitis. Again, hepatitis is a disease in which questions are asked very minimum and they are from the markers. Now let us talk about the markers. And markers you already know in your microbiology. Just two or three things I'll discuss because that is already discussed at length in your microbiology sections, because that is a very important disease which they tell you. Okay, so one thing, but the only thing Karam said yes, Bilaspur is also saying done. The only thing which I would like you to know is epidemiological marker. Epidemiological marker. So kindly tell what is the epidemiological marker of hepatitis B, and then we'll move ahead. What is the epidemiological marker of hepatitis B? No, you all are wrong. Anti-HBC AG, or it is also known as HBCAB. HBCAB. So it is antibody against HBC. So please make this correction. HBC. That means antigen is HBC. Against that is the epidemiological marker. So Kolhapur, you were saying surface antigen. That is a very old concept. It has already gone. You should say that epidemiological marker now is anti-HBC AG or HBC AB. Antibodies against HBC. That is why, and that's the reason I know that this should also be covered in your this IgM anti-HBC AG. Mysore is absolutely correct. It is this antibody against C which is the epidemiological marker, and you should also always write there is a a logic behind this, and that is that it is present. It is this antibody is present in current or past infection. And that is why epidemiologically, if we have to go, we will go with this. They are saying first earliest marker. Jammu is asking, yes, earliest marker, there is no change. We know clinically earliest marker is HBsAg. So earliest is HBsAg. So if suppose somebody is asking earliest, then it is surface antigen. Then there is HBeAg. The picture which they told you in your microbiology section, that is absolutely true, that HBsAg is the first, then the next one is HBeAg. That is something which is there. Bilaspur and Visakhapatnam is asking about this is, you can have a look on this. Earliest is HBsAg, and then there is HBeAg, but anti-HBC is this. They are asking about HBV DNA. HBV DNA is a marker of infectivity. Always remember, viral activity. Okay, viral activity. Medicine says HBS, Allahabad. No. Only follow epidemiological marker as anti-HBcAg. Okay, and Bilaspur is asking micro faculty tells DNA. No, it's not. You must not have heard them clearly. DNA is there. It is a specific marker of viral activity. Make this change. Specific marker of viral activity is HBV DNA. That is very true. He is absolutely, or she is absolutely correct when she or he told you about this, that the specific marker of viral activity is HBV DNA. Okay. And then if HBV DNA is not there, then the second one is HBeAg. So that is something. So E. So you have to have a choice between HBeAg and HBV DNA. When somebody asks you about the surface antigen is the first antigen to appear. But if somebody asks you about the epidemiological marker, then believe me, you should remember that the epidemiological marker is actually anti-HBC. Okay, Mysore is asking yes. That's why you are saying IgM. Yes, IgM is usually seen in current. I agree. This is IgG which is seen in past infection. So that's why we never write the as somebody has written very characteristically IgM, so that we usually avoid. But the epidemiological marker, beta, always remember, is antibodies against C. That is very important. So there is no such confusion. But I agree with Mysore. IgM is usually we say for the current infections. Okay. Now let us come to the second one. As every one of you agree that this topic is being covered very much in your microbiology. Which is more prevalent in India, hepatitis B or C? It's a very different kind of question, because in all blood products, the HBC is the most problematic. But HB Jammu, he's not asking about E, he's asking just B and C. Then if he's asking about B and C, so I will go with C, because C is seen in blood products. Chronic, once it's chronic, it's chronic. Okay. Now let us come to one other very important. Now come to cholera. And when there is cholera, then cholera means, again, the questions which are asked in your entrance exam from the microbiology, when they say that it is more kind of questions when it comes to the characteristics of L-TOR versus classical cholera. So we are not going in detail of that. Just you also know, me also know, that the most effective measure of control of cholera is hygiene. So if we maintain hygiene, that is very important. And the second most important for cholera is ORS. So these are two things which should be known to us, that the most effective way of controlling is hygiene, and most important is this, which is the most commonly transmitted by blood transfusion, HBV or HBC, HCV. Bataiye, Mysore is asking which is most commonly transmitted by blood transfer, HBV or C. If suppose this is the question, then we believe you should say Allahabad, as they are saying, H, B or C, most commonly transmitted. Dekho, one thing which you should remember, that there is again a catch in all these questions. Okay, because earlier, from the very earlier days, it is known that all blood banks were having a certificate of having screening for C. So if suppose this is a question between, you have to choose between B or C, it is always better, beta, to go with C, because C are most commonly seen. And the earliest versions, this HBV is being given now only. C has been there for the earlier days. So it's C. So it's B or C, you should follow C. That is very important. Now most effective is hygiene and ORS. Then what is the chemoprophylaxis? And chemoprophylaxis is, when they say yes, chemoprophylaxis, it is doxycycline, 300 milligrams, 300 milligram, and that is adults, single dose. Single dose. So single dose. Okay, Mysore is saying the grand test answer given was HBV. Okay, it's HC. It's C actually, and that is, I believe, the reason the students are saying B. Okay. So it is doxycycline. It is 300 milligrams adult single dose. Okay. The second one is cotrimoxazole. Cotrimoxazole. Children. And when we say it is for, third one, furazolidone, it is for pregnant women. So these are three questions, as I told you earlier, that earlier when there is a question, Mumbai is having frequent disconnection, so we'll try to look for that, and I'll tell Mumbai, please don't worry, I'll ask these people that they should look to this. So furazolidone is for pregnant women. So pregnant women, cotrimoxazole children, and doxycycline is adults, which is important. So that is very important questions. Now, what is the confusion? I'll tell you what is the confusion even in these kind of questions. Sometimes they ask you chemoprophylaxis in adults, and they give you option as doxycycline versus tetracycline. Doxycycline versus tetracycline. And always remember that when they say doxycycline versus tetracycline, the question goes in favor of doxy only, because you already know in pharmacology that tetracycline is actually the major and doxycycline is specific. So in some of the guides they have also written tetracycline. This is again a confusion, and doxy is also given. So which to follow, which not to follow. So always remember, because it's 300 mg doxycycline, very specific, single dose, so it's better to go for doxycycline. So answer should be doxy in that case. Okay, so as I told you that most of the questions from cholera are from the sections of what we say as the questions from specifically from microbiology. So let us move ahead, and when we move ahead, now let us come to different disease in that order. And we'll take again the controversial question first of this disease. I believe this will again put you in lot many confusions when I start telling you about few things. And when it comes to leprosy, I believe your dermatology class would have been over now till now. But what are the questions which are there from our section is, number one is, it was eliminated in which year? So elimination. So elimination was done in which year? Elimination was done in year 2005. And that was very good. And the case was less than one case per 10,000 population. So when there is a one case per 10,000 population, the elimination of one is done. Elimination. There are very many questions which are popping up, and that's why I'm not able to sometimes look to things which I'm writing. As somebody was saying that let us take them, you can write them on a sheet of paper, we'll discuss it, because otherwise it would be a difficult task, bacho, and that is the reason sometimes I'm writing some options or some of the things wrong, and then I get back to, oh, I have written that. Okay, because I have to look for two at the left, at the right. So most of the time, so it's a bit difficult. Okay. So elimination is 2005, and it is less than one case per 10,000 population. Then what is the case? What are the questions which are asked in this? And that is, when we say elimination, it is already there. Now the questions which are asked from our section is, yes, I was saying because you said that the dermatology section is over. Then the second question is, what is the criteria for SET centers? SET centers are survey, education, and treatment. And these SET centers are when we say that it is for 20,000 to 25,000 population. So every 20 to 25,000 population there was one SET center which was formed. And it is very important, bacho, to understand that these SET centers are for survey, education, and treatment. Then they again ask you about very important concept, and then they say that there is one very important LCU, which is also known as leprosy control units. And one leprosy control unit was for 4.5 lakh population. So 4.5 lakh population, one LCU was there, leprosy control units, and one SET centers were there for 20,000 to 25,000 population. Then they do ask you one more important question, that presently it is a camp based approach which has been running. So what it is known as, always remember, presently it is MLEC, which is also known as, we call it as modified leprosy elimination campaign. Modified Leprosy Elimination Campaign, MLEC. This is actually currently going on. It is a camp based approach, 1 to 2 weeks camps. So 1 to 2 weeks camps are done, and it is MLEC, and they say that it is in phase 2, presently in phase 2. Phase 2, and in phase 2 there is one round in 1 year, one round per year. Okay, so this is MLEC, or which we call as Modified Leprosy Elimination Campaign, which is going on. Then they say that Government of India is also running a program which is known as SAPEL, SAPEL, SAPEL. SAPEL means Special Projects for Elimination of Leprosy. Special projects for elimination of leprosy. And the question is asked that this SAPEL is in which states or districts. These are for tribal and hard to reach areas. In tribal and hard to reach areas, SAPEL or Special Projects for Elimination of Leprosy is being conducted. Now again, as you know, as you said that this question is already done in leprosy, is already covered in your Dharma. I'll come to it's again a programmatic part, and the last section of leprosy. We'll not go in details of leprosy now because Dharma people have covered the entire topic, and that is when we say diagnosis at field level, it is done. Diagnosis at field level, it is only 2. So it is, we say if it is less than equal to 5 lesions or anesthetic patches, or more than equal to 6 lesions or anesthetic patches, and this is known as paucibacillary, and this is known as multibacillary leprosy. Then the question is asked that which is known as defaulter here. Defaulter in paucibacillary case. So always remember, if 6 months treatment cannot be completed till 9 months. So if 6 months treatment cannot be completed till 9 months, he or she is a defaulter in paucibacillary. And here, if 12 months treatment cannot be completed till 18 months, he or she is a defaulter. So this is again a very important concept which you should remember, that here the defaulter is who is not having treatment till 18 months of age, 18 months of treatment, and person who is not having paucibacillary. Then again there is a very important question which is there, and as the sheet is not given to you, so I'm looking for that. But anyway, the question says that as per NLEP, National Leprosy Elimination Program, treatment of single lesion leprosy, and that is similar to similar to paucibacillary. But if it is as per WHO, it is still Rome. You remember, Rome is rifampicin, ofloxacin, minocycline. But it is not followed in India. So NLEP says no to this. They say no, we will use possibacillary only. So we will use the same thing for 6 months. But WHO still says that Rome therapy can be given and it's very effective. Rifampicin, ofloxacin, minocycline. But in India we do not follow this. Okay, so that is something which you should remember. And last but not the least is, if somebody asks you which is the most common leprosy in India, that is borderline tuberculosis. So borderline tuberculosis or BT is the most common leprosy seen in India. So that is something which you should remember. So now we are moving ahead, because leprosy is already covered. It's one of the major portion. They sometimes ask you that which organ is spared if there is an attack of leprosy, and in some of the books it is written, in some of the guides it is written that uterus should be the answer. If there is any question that uterus is usually spared when there is an attack of leprosy, you can write this as AIMS, just for learning or just for remembering question from AIMS or All India, because bacho, always remember that Mycobacterium tuberculosis or Mycobacterium leprae do not spare any organ so far, but this is this. Then there is another very important question, and the question says that the next question is for plague. And when we say about plague, the questions which are coming from the section of plague are about incubation periods, which we know, pneumonic, bubonic and septicemic. And pneumonic is 1 to 3 days, it is 2 to 7 days, and it is 2 to 7 days again. Now what are the questions which are asked in entrance exam? Then answer would be pneumonic is most communicable, bubonic is most communicable. So what is most communicable? Pneumonic is most communicable plague. But if it is asked most fatal plague, it is septicemic. So always remember, the changes should be done, that most communicable is pneumonic, most fatal is septicemic, and most common, we all know is that most common is bubonic. So most common is bubonic, most communicable pneumonic, and most fatal is septicemic. Then they ask last case of bubonic plague. Last case of bubonic plague was reported, or last outbreak you can also say. Last outbreak of bubonic plague occurs in Bid, Maharashtra. Last bubonic case was seen in Maharashtra. But if they ask you regarding the last pneumonic case, then you should remember that the last pneumonic case occurs in Uttarakhand. Because this is a change. It's the change. Okay, so it is Bid, B-E-E-D, Bid. Bid, name of the place in Maharashtra. Maharashtrian people know that it is place Bid, B-E-E-D, Bid, Maharashtra. Then pneumonic is Uttarakhand. Then they ask you that in this when the questions are asked from this section, because now in your previous edition park it was written that the pneumonic plague lastly occurred in Himachal Pradesh, in Simla, Hatkoti, but there was then a change was made that the last case which was reported was, or the last outbreak which was reported was from Uttarakhand. The bubonic was Bid or Maharashtra place. And the third one is, which is very important for you to remember, is about its DOC. If DOC is there and DOC for treatment, the DOC for treatment would be streptomycin. But bacho, if they ask that what is the DOC for chemoprophylaxis, it is tetracycline. Tetracycline for 5 days. We know that tetra for 5 days is given, and this is the chemoprophylaxis for plague. You also know that plague is also known as the marker of hygienic condition in any country. Hygienic conditions surrogate marker. Hygienic condition surrogate marker is plague. Surrogate marker, you all understand. That means if in a country disease like plague is occurring, that means it is the you should say that it is very hygienically low standard country. Last case of plague, if it is asked that which is the last case of plague occurring, always remember last case of plague is अभी तो नहीं ब्रेक, अभी तो 11:30. Okay, so if they are asking if last case, then again Uttarakhand will be the last case. So Uttarakhand is the last case which is there. So hygienically condition is a surrogate marker, and that was this, as we say, it is plague which is occurring. Okay, so yes, then the question which is there from the section is about very important questions now we are coming to, and these are flea indices which are very important, and these flea indices which we say is from 2002, Vishakhapatnam 2002, we should remember. Then flea index is total flea index. Now we'll take one by one questions. Total flea index. Total flea index is what? Now we'll taking, yes, Aligarh. It is flea index, total flea index. Okay, repeat, Aligarh. No, we are saying just at 11:30 we'll have a tea break. What is the total flea index? Average number of fleas of all species per rat. Average number of fleas of all species per rat is known as total flea index. So very important question asked in your entrance exam so many times. Average number of fleas of all species per rat is known as total flea index. Then Cheopsis index. Cheopsis index. What is Cheopsis index? Average number of Xenopsilla cheopsis. Average number of Xenopsilla cheopsis per rat is Cheopsis index. And then they ask you, what do you understand by, or what is the importance of Cheopsis index? It is the indicator of potential explosiveness of plague. Indicator of potential explosiveness of plague. Potential explosiveness of plague is Cheopsis index. Then there is third which is very important, and that is known as Burrow index. Burrow index. And Burrow index means average number of fleas per species per rodent burrow. You remember there is a question in entrance exam that once a burrow is infected, it will be infected for how many years? For life, we say. It is more than 10 years actually. So burrow indexes, when we say average number of fleas per species per rodent burrow, so that is very important, and that tells us that if there are infected burrows in that area, the potential of getting plague would be more in those areas. So we always say that this is a very important index and for getting an idea about conditions which may occur because of this. Now there is very important question again, and then they say, when do you say area free of plague? Area free of plague. When no new case occur, when no new case occur, when no new case occur from number 1, 3 months have elapsed. 3 months have elapsed since last case seen in wild rodents. What we have said, that area is said to be free of plague when no new case occur from 3 months, for 3 months have already elapsed since last case seen in wild rodents, or number 2, 1 month elapsed. 1 month elapsed since last case seen in domestic rodent. And third one is since twice the incubation period in humans has elapsed. So that means when all these three are seen, then we say the area is free of plague. So it is all. So we need all together to declare an area free of plague. This is not or. So either 3 months have elapsed, not either. We should say that no new cases are seen in wild rodents, and the 3 months have already elapsed when the last case was seen in wild rodent, and side by side 1 month has already elapsed and no new cases are seen when it was seen in domestic rodents, and the last one is twice the incubation period in humans has elapsed and no new cases seen. Most sensitive index for plague, for out of whom you are saying, if suppose you are saying this, then the Cheopsis index would be most sensitive. You are saying most sensitive index or most specific, that's also very important. Haldwani, है ना? So actually Miraj is asking about most sensitive index. Okay, but if suppose you are saying, because again the question can be sensitive or specific. When we say sensitive, then total flea index, if suppose that is in question, total flea index would be better. Sensitive, most sensitive is total flea index, but if you say most specific index, I will say that it will be Cheopsis index, because Cheopsis index specifically look for Cheopsis only. Then there is again one question from plague category, and that is bacho, when they ask you another very important question, and they ask you that when do you say that there is an effective control of plague, you should say that within, right, that after in 48 hours of insecticidal spray, after 48 hours of insecticidal spray, After 48 hours, okay, not notepad, we are looking for that, we'll get it again. So right, but after 48 hours of insecticidal spray, rotated, yes, we got it. After 48 hours of one thing, got it. Repeat from start. Okay, I'm repeating it, Karam, so don't worry. When do we say effective control of plague? So effective control of plague is said to occur when we say within 48 hours of insecticidal spray, Xenopsilla chiopsis index must drop down to 0. Now that is very important. What we have said, that what is an effective control of plague? Within 48 hours of insecticidal spray, Xenopsilla chiopsis index must drop down to 0. So that is very important, and that bit you need to remember. Okay, and that is already, I hope you remember that well when I told you earlier that this disease, or in this disease, or in the area where the plague is there, we should remember that 3 feet height from the floor should be covered with DDT or any insecticidal spray. So from the floor, 3 feet height should be covered with insecticide, if suppose we wish to have an effective control of this virus. Oh, sorry, not virus, sorry, with this disease, or with fleas. Okay, now much has been told about plague. Now let us take a different disease altogether, and that is rabies. Now what are the questions which are asked from this section? You already know the very important question which they ask from rabies is about its virus, which you study in your microbiology classes. But there are two types of viruses which we say, just 2 words about those, and one is known as street virus and the other one is known as fix virus. The only thing which I wish you to remember for your epidemiology or for understanding this disease well is that the incubation period in street virus is 6 days to 60 days in broader way. But when we say the incubation period for fix virus, you should remember it is 2 days to 6 days. So 2 days to 6 days is the duration or incubation period where we have this fix. Always remember, this fix is actually the vaccine virus, and that is the reason if I ask you that rabies vaccine should maximally be given till 6 days of exposure. As you remember, we learned that thing in measles also, that measles can be given post exposure. And when we say measles is given post exposure, then we remember saying that it should be given post exposure within 3 days of exposure only, within 3 days of exposure. But if suppose I say no, tell me about rabies, you should say, because rabies, the vaccine virus takes maximum 6 days, and this street virus takes minimum 6 days. So every possible effort should be made to vaccinate the patient within 6 days of animal bite. Now the question says, what is the vaccination type which we are using in India? What is the difference between these two strains? Beta, as I told you that actually the street virus is the original pathological virus which is seen in a rabid dog, and then you take that virus out and then you try to fix it by passing them with the successive steps on the mouse brain. then that gets fixed. The incubation period gets fixed. The same kind of virus is used in your vaccine. So that is something which is, attenuated virus, which is used for vaccine purpose. So this is that fixed virus which is being used. Now there are very many methods, but initially Pune lab was using just this method when they used to take this fixed virus and then they convert it into a vaccine strain. Okay, so that is something which you should need to remember, that fixed virus is what is being used earlier for that vaccine preparation. Now we have all those DNA techniques, human, that is being used, but it's that which we have been using for making vaccine. Now the schedule. Now rabies vaccination, and when we say rabies vaccination, it is of 3 types. One is known as pre-exposure vaccination, post-exposure vaccination, and post-exposure in pre-exposure received. Pre-exposure received. When we say pre-exposure vaccination, you all understand, pre-exposure vaccination is for veterinary doctors, and it is actually 0,728 intramuscular doses. So pre is for veterinary doctors. For veterinary doctors we give this vaccine. So for veterinary it is 0,728. When we say for post exposure, it is actually of 2 types. One is intramuscular and the second one is intradermal. When we say intramuscular, it is again of 2 types. One is known as Essen's regime and the other one is known as Zagreb regime. And when we say Essen's regime, this we have been using for a long time. It is 0, 3, 7, 14, 28, 90. It is also known as 1, 1. You can write 1, 1, 1, 1, 1, 1. This is optional, and that is why it is known as 5-dose regime. So 5 dose is Essen's regime, 0, 3, 7, 14, 28, 90. So it is Essen's regime. When they say Zagreb regime, Zagreb, it is 0, 7, 21 regime. It is 2, 1, 1. It is 4-dose regime. So intramuscular regimes are 2. One is Essen's, the other one is Zagreb. 0, 3, 7, 14, 28, 90 is 5-dose regime. Optional is 90th. Zagreb is 0, 7, 21. If they ask you about ID regime, again of 2 types. The one, it is known as 8-site regime. 8-site. It is also known as Oxford regime. Oxford regime. 8-site regime or Oxford regime. It is 0, 7, 28, 90. 0, 7, 28, 90. And it is 8, 4, 1, 1 regime. 8, 4, 8, 4, 1, 1 regime. 8, 4, 1, 1 regime. So if suppose somebody asks you this Oxford regime, then you will say it is 8, 4, 12, 13, 14. It is 14-dose regime. Oxford, 8-site regime. It is given in your park also, where they have made one diagram and they have made cross this way. The second one is known as 2-site regime. 2-site. It is also known as Thai regime. Thai regime. It is known as Thai regime, and it is 0, 3, 7, 28, 90. We call it as 2, 2, 2, 0, 1, 1. So it is also known as 2, 2, 2, 0, 1, 1. 0, 3, 7, 14, 28, 90. It is also known as 2, 2, 2, 1, 1. And right here, it is recommended by government. Recommended by Government of India. So GOI regime is Thai regime which Government of India is saying. How many doses? 2, 2, 2, 0, 1, 1. 0, 1, 1. So it is 2, 2, 2, 6, 7, 8 dose. It is 8 dose only. Okay, so Thai regime is there. Always remember that if somebody asks you that which is the most effective regime, Aligarh is saying why 0 is written. Yes, you may write it as 2, 2, 2, 1, 1 also. Aligarh, there is no question, because this question is asked so many times by students as well as doctors, that why do we call it like this? We can call it like this also, 22211 regime. You can also call it like this. There is no question. But if suppose they give you like this, 222011, you should remember these are same thing. This same. Some doctors, some of the books, they write as 22211. Some write 222011. That's the same thing. Okay. So that is, this regime is approved or recommended by Government of India. But yes, I was telling you that if suppose somebody asks you post exposure, Karam sir, but what is left? And pre-post. Post though I have not yet, pre-post I have not yet told you. But the post I have already told you. Karam sir, post is two. One is intramuscular. Intramuscular is Assens Zagreb. 037 14 28 90. This is optional. This is something which is known as Assens regime. Intramuscular dose. 5-dose regime. And when you say 0721, 0721, this is Zagreb. This is Zagreb. This is 211. And when I say intradermal, then intradermal are 2, and when I say intradermal, the recommended by Government of India regime ID is Thai regime. Thai regime is also known as 2-site regime. We call it as 037 14 28 90. So we write here 222011. So that is something which is known as 22211 regime or 222011 regime. The second one is known as 07 28 90 regime. This is Oxford regime or 8-site regime. So here it is 8411. Now let us come to the third, and that is known as, now let us come to third one regime, and that is known as if a dog bites a doctor. And can't we write it as 037 28 90? Jammu is asking, yes, most effective of these. Yes, Mysore, yes, I was telling most effective of these is 8-site. 8-site is most effective, but it's not yet in vogue. Can we write it as 037 28 90? Who? Which? Jammu, are you asking, can we write it? Which regime you would like to write as 037 28 90? Thai regime. Thai regime, you can write. Yes, you can write regime as 037 28 90. Yes, very true. That was, I was telling it to Aligarh students also. Allahabad, most common is Thai regime. No. Most common still, in your states also, most commonly used is still Assens regime. Assens regime. Most commonly followed in India is Assens regime. But Government of India recommends now. This is very important, a tricky question. If you ask your medical officers of your PHC, they will tell that we still use, intramuscular doses. So most commonly that is being used. But if somebody asks you recommended by Government of India, Thai regime. Government of India is saying Thai regime should be used. But still we are using muscle. But if it is asked most effective, it is 8-site regime. And you can understand by logic also that within a single day, 8 doses are given. So maximum coverage is given. Okay. So that is something which is important. Now the third and the last question from rabies, and that is, if a dog bites a doctor, veterinary surgeon, so post pre received, if he has already have this, yes, very good, Jammu know the answer, but you should know that if antibody titer is less than 0.5 international units. If antibody titer is less than 0.5 international units, then it is 037 IM dose. But if it is more than equal to 0.5 international units, it should be 03. That you should remember. So the answer can be 037. The answer can itself again be 0, 3 and 7. So it can be 037. It can be 03. Depends what kind of question are we, getting. you can have a look. Vishakhapatnam. If antibody titer, antibody is in which? Is in whom body? Antibodies are in doctor's body. So we have to check that titer. If suppose the protection in the doctor's body is good, it is it is more than equal to 0.5 international units. It's better to give only 0.3. These are intramuscular doses. But if they say no, the antibody titer is less than 0.5 international units, so doctor needs protection, so we'll give 0.37. But as the Jammu students say very clearly that sometimes they don't mention in question that what is the antibody titer in doctor's body, then it is always safe to go for 0.37. Now there is a question in entrance exam back here, and then they asked that there was an unprovoked bite. I'm writing this question. Aims. Unprovoked bite by a pet dog. What should be done? The question was unprovoked bite by a pet dog. What should be done? Again, always remember, bacho, that if it is an unprovoked bite by a pet dog, first of all, 0.37, these doses must be given. No, nothing. Haldwani notes a wrong answer, bache. Always remember, it is an unprovoked bite. If it is an unprovoked bite, it should be given, because pet dogs, they don't usually bite. So vaccination previously have post-exposure within 2 years. First of all, let us take pet. Yes, Jammu, I agree, it's pet. This dog was a pet dog. That means he or she should be vaccinated. He dog, she dog, whatever, they should be vaccinated. But we should get it as very important that it was an unprovoked bite. If it is an unprovoked bite, it is an indication that maybe, during the morning walk or during the evening walk of dog, this dog would have been in contact with some rabid dog and they got this. So this 0.37 is to be given, and 10-day observation of dog should be done. Always remember, if it is a provoked bite, that's what the catch is. If it is a provoked bite by pet dog, if it is a provoked bite by a pet dog, nothing is to be done. But if it is an unprovoked bite by a pet dog, observation should be done, as well as this should be done. So why can't we observe? Yes, we should observe. We should observe. Jammu, we should remember. But 0.37, again, get that thing in your mind, that we should get the maximum protection within 6 days. As I told you earlier, when we start the rabies topic, that within 6 days, maximum coverage should be given. Okay, so that is very important, which you should remember, that in 0.37, this should be given. And the next is this. Vaccination in a person previously having post-exposure within 2 hours. Any time relation? No time relation. No time relation actually. Dibrugarh. Okay, then these questions are just made for this purpose only. Okay. Allahabad. Doses is 0.37. That depends. That if it is intramuscular, you should give 1.11. If it is thigh regime, you should give it in 2.22. That is there. Okay. That is very important. Protection lasts for how many year long? Jammu, there is no such study which are showing that. That's the reason. Jammu, get back to that we have to go for the immunity titer, antibodies titer. If it is less than 0.5 international units, again you have to give it. So there is no such study which are showing that it is giving protection for. Means if a person is kept on being bitten by dogs, stray dogs, he needs these vaccination again and again. So, okay, so always remember, it's not a live vaccine, it's a dead vaccine, and dead vaccines need multiple doses and they need boosters. Okay, so that was from the section of rabid dogs. So we should start having another disease, and then we'll go at 11:30 for a small tea break. And that is, the questions are asked for from the section of let us take now the vector-borne diseases one by one, because that is very important. As I told you that previously, this year is being announced as a year of vector-borne disease, small bite, big threats. So it's the time for us to go for the first and the very important disease, and that is dengue. Now what are the questions from dengue? We all know that dengue is again a portion, or the questions where the questions are asked from the medicine section. but let us take the strains, and we all know the strains of dengue are 1, 2, 3, 4. So 4 strains of dengue are known to occur. Then the incubation period, if it is DF or dengue fever, it is 5 to 6 days. And if it is DHF or dengue hemorrhagic fever, it is 4 to 6 days. So nothing to worry. Very easy to understand that in dengue, the DF or dengue fever 5 to 6 days, and it's DHF hemorrhagic fever 4 to 6 days. How will we make the field diagnosis? Field diagnosis for dengue fever. And when there is a field diagnosis of dengue fever, we should know it is high grade fever. High grade fever, which is biphasic curve. High grade fever, which is biphasic curve. Yes, very good. This is breakbone. This is the saddleback. We all know. There are chills. There is very important intense headache. There is very important muscle and joint pains. Muscles and joint pains, intense headaches, chills, and then there is very important part, and that is orbital pain. And last but not the least is rashes. So these are some of the things which are seen in cases of, these are retroorbital pain, which is a very characteristic of, sometimes we have these kind of things, retroorbital pain, which is very important in cases of having a field diagnosis. That's what I told you. It's field, it's not the lab diagnosis. It's the field diagnosis of DF or dengue fever, only dengue fever. Then what is the DHF? And we know in DHF, to call it as DHF, you need DF plus minus rashes. So rashes can be there, cannot be there. Rising hematocrit values. Rising hematocrit values. Rising hematocrit values. Hematocrit is rising. Then there is very important thing which we should understand, and that is moderate or marked thrombocytopenia. So for making a diagnosis of DHF, we need to have laboratory support always. So moderate or marked thrombocytopenia. For us, it is less than 1 lakh if we say for field reason, and it can be hepatomegaly. And last but not the least is positive tourniquet. Positive tourniquet test. And when we say positive tourniquet test, it is more than 20 platelets per square inch. More than 20 platelets per square inch should be the amount, the number of petakis which should be there per petakis. Yes. Oh no, I've written platelets. Petakis. Number of more than equal to 20 petakis. More than equal to 20 petakis per square inch should be there to get an idea about having a field diagnosis of this. Jammu, take a break. Yes, we are going for a break, dear. Just 5. Yes, I also need a break. You are saying yes. That's very true. So nice of you. Now anything is, no, it's not any criteria. Yes, they say for rising hematocrit, it's a clinical criteria, beta. Rising, we say it is more than 20% of the baseline. As is been asked by Kolhapur, that what if we say rising hematocrit? Then if we say rising hematocrit, it is actually the same thing which we take in clinics, that it should be more than 20% of the baseline values. Okay. Okay, then the question is, Mumbai is saying lag between this AV and this. We'll try to look for this. We'll try to look for this problem in, they are saying that there is a lag between this. Okay, they are checking that up. But before that, let us have a very important question. Okay, and that question is for the index. That is very important. It's a most common serotype 1. Okay, we are coming to that. O type is blood group O, they are saying. Blood group O are more susceptible to get this disease, beta. O and AB are the least one. Okay. So now the last, and then we'll go for a tea break. I agree. The thing is about AD's index. AD's index. And AD's index is, when we say, these are three in types, and that is, which we say as, number 1 is house index. The second one is known as container index. House index, container index, and the third one is known as Preventive. House index, container index, and Preventive index. So when we say house index, that means percentage of houses, house, Preventive, agroising spell, Preventive, Breuteux, Breuteux, Preventive index. You must have heard this term, Aedes aegypti index. This is the same thing, Aedes aegypti. Aedes aegypti or Preventive index is this. Okay, so what is this house index? Percentage of houses in premises of which, percentage of houses in premises of which breeding of Aedes mosquito seen. Percentage of houses in premises of which breeding of Aedes mosquito seen. That is known as house index. So very easy to remember. Just the names are a bit, different, or not difficult, I should say different or vague. What is container? You can understand it by logic. Percentage of containers in which breeding of Aedes mosquito seen. So the same thing. So house index means how many percent of houses have positive breeding. Container means how many containers are positive for breeding. And what is Preventive index? Percentage of containers per house. Percent of containers per house. So when we say percentage of containers per house in which active breeding of Aedes mosquito seen, that is something which is known as Aedes. So it is a composite index. In your UPSC exam, you must have seen that. Mangalore is joining now. Hello sir. So you are very late, I believe, Mangalore. But anyway, so it is, you are most welcome, Mangalore. So it is containers. So percentage of containers per house. So that is something which is known as Aedes aegypti index. So what is Aedes aegypti index? It is that which is very important. And I believe for dengue it is not that important, but it is important, you all agree, for yellow fever. You remember that yellow fever index? I'll tell you what. And that is in yellow fever, right? In yellow fever, what we say in yellow fever, it is right, for effective control of yellow fever, for effective control of yellow fever, Bikane, we are going for a break just after this. For effective control of yellow fever, Aedes aegypti index should remain less than 1. Effectively 0 within for effective control of yellow fever, Aedes aegypti index should remain less than 1, effectively 0 within 400 meters, within around both, within and around 400 meters of international airport. So that is very important for us to remember. What is that? It is that if we want an effective control of yellow fever, Aedes aegypti index should remain less than 1 or effectively 0 in and around 400 meters of international airport, and that is what we require. You all understand Aedes, the range of fly which we have already discussed in our earlier sections or sessions, that was 100 meters only. So we have taken 4 times of that, and what we are trying to have is that the breeding sites must not be there for the effective control of yellow fever. So I agree. Now it's the time for break, so we'll be back after this. Yes, Jabalpur, we are going. Thank you. Okay, so now we are back, and let us hope that rest of the batches have also joined us. So now we are going to start, and we have already gone through the malaria drug policy. The second thing which we are going to start with is the yes, Allahabad is back. I hope rest of the batches are also back, because we are going to start the last session or the interaction, because from 2 onwards I believe you are having your radio diagnosis class. Anyway, now let us start, and now we are having the another section which is very important, and that is malaria. We have talked about the malaria drug policy. Now what are the things which are asked from malaria? Now we'll understand those questions first. And when the questions are asked about malaria drug, the most important things are from the specific programs which were made against malaria. Animal bite categories, Rotak is asking. Rotak, dear, you are saying about your animal bite categories. I believe you are talking about category 1, category 2, category 3, not the animal bites. I believe you are talking about that essence regime which follows some categories. Like category 1 is just when there is no oozing of blood and just scratching. So what you can remember, Rotak, is that this when we increase the categories, category 1, category 2, category 3, the severity increases. And when there are multiple bites, when there is bites on face or anything which is closer to central nervous system, that is a category 3. And then there is this category 1 and category 2 are those. Okay. So now let us talk about, yes, they are saying as covered in micro. Belgaum is saying yes, how frequently in the cholera epidemics that we know. Okay, now the question which are coming up now is malaria. Now let us talk malaria first, as the questions are being asked, and one of the questions in between is that, is this the last class of PSM? As per schedule, it is the last class of PSM beta, and that is why I'm a bit skeptical when I'm saying that let us cover most of the portions today, because your exams are also announced, and we have this pressure of getting all the batches covered. So now let us first get to what can be done till 2. We'll try our level best to go. Karam said, very true. So malaria. Now let us talk about malaria. The questions which are asked from malaria is MPO. We all know what are the questions of MPO. MPO is modified plan of operations. Modified plan of operations. And when we say modified plan of operations, always remember in 1977 it was launched. So in 1977 it was launched, number 1. Number 2, you say what is modified. The question is asked, what is modified, or what was modified? Why we called it as modified? It was because there was a change from National Malaria Eradication Program. National Malaria Eradication Program. 2, very good. National Malaria Elimination, or rather we should say control. National Malaria Control Program. So there was a change from National Malaria Eradication to National Malaria Control, or NMCP. That is what they did. Now that was the question, that under MPO, so at the time when under MPO, the areas were divided as API, annual parasite incidence, or API. So less than 2 and API more than 2. Mysore, malaria covered. No, this portion must not have been covered. These are just programmatic part, bache. We have done about malaria drug policy. So just a few points on, very crude points on the program. Just program. Okay. So API less than 2. So what is API less than 2? Always remember, API less than 2 says what are the things should be done. In API more than 2, what are the things which should be done? Let us take first API more than 2. And in API more than 2, they say regular insecticidal spray should be done. Regular insecticidal sprays. Regular insecticidal sprays should be done. Number 1. Number 2, there should be entomological studies. Now this is very important. Entomological studies. Number 3 is malaria surveillance. So what are the things? Regular insecticidal activities. Number 2 is this regular insecticidal activities, entomological studies. Yes, we are getting those notepad corrected. Regular insecticidal activities are done, entomological studies are done. The third one is malaria surveillance. The fourth one is treatment of cases. So all things should be done. Treatment of cases. And you know, the question which is asked in your entrance exam is, when we say treatment of cases, the treatment of cases will be done in, we have drug distribution centers, DDCs. Drug distribution centers. Treatment is, when we say it is DDCs, drug distribution centers, and FTDs, fever treatment depots. DDCs and FTDs. So what is DDCs? Drug distribution centers. And when we say FTDs, it is fever treatment depots. Okay, so fever treatment depots and drug distribution centers. And always remember, when we are saying this, it means just drug distribution centers, means just drug distribution only. And when we say fever treatment depots, FTDs, you should remember FTDs means, okay, again notepad problem is going on. He'll correct it. When there is fever treatment depots, always remember fever treatment depots have both the facilities of drug distribution as well as of making slides. So slides as well as just the drug distribution, both is done. I believe you are getting those notepads. So distribution of drugs plus making of or preparing of slides. Then the question is asked that what actually is, if API or annual parasite incidence is less than 2. Is trying to get that completed. Okay, notepad, yes, they are getting that notepad correct. Okay, what about if there is, you know, this API less than 2? When API is less than 2, what things should be done are, number 1, if it is less than 2, focal, this is very important, your AIMS entrance exam question, there should be focal spray. of DDT, there should be active surveillance. Now this is very important, bacho, because most of the time we have this idea that if there is an area where the problem of malaria is high, active surveillance should be done there and there only. No, we should remember that active surveillance should be done in those areas where the problem of malaria is less. People will not be aware, and it is our duty to look for, to actively search for those cases. So second is active surveillance. The third one, which is also very important, is that here epidemiological investigations should be done. Epidemiological. What is happening? Epidemiological. There is some problem going on. We are trying to get it corrected. Okay. So now there is epidemiological studies. Acha, what is new now? Now this was as per the guidelines which were given at the time when MPO was there, or modified plan of operation was there. Now the thing which you should remember now is that nowadays API, which type of malaria surveillance? Yes, Agra is asking that if it is API more than 2, always remember both surveillance are required, active as well as passive. But if you have to choose out of these two, you should choose passive. So if API is more than 2, passive should be there as well as active should be there. For less than 2, active should be there as well as passive should be there. So both should be there, but the stress should be more on passive if it is more than 2, and it should be more on active if it is less than 2. So that is one of the things which you should remember. Now the next in the order was, which is very, very important for you to remember, and that is a different plan. We call it as rollback malaria. Rollback malaria. Rollback malaria. So the thing which you should remember about rollback malaria is very important, and that is in rollback malaria there was an integrated approach which was used. Integrated approach for control of malaria. Integrated approach for control of malaria was used. You may ask me, what is that integrated approach? Number one is like source reduction. Source reduction should be there. Number two, research on new insecticides. Research on new insecticides should be done. Number three, quality treatment. Should be done. So the thing, quality treatment as well as quality microscopy. As well as quality microscopy should be done. So nothing, nothing more, what you call it as, it was the same thing which was going on earlier also. But for your entrance exam, you should remember just one thing, that these are, that we say earlier also, that old wine in a new bottle. They keep on, getting all those previous concepts in new programs. So just the same thing, source reduction, research on new insecticides, quality treatment, quality microscopy, all those things were done. Okay. Then the next program which they launched was EMCP, Enhanced Malaria Control Program. No, that year is not important because rollback malaria is still there. With the help of WHO, I'll tell you, with the help of World Bank beta, another program is launched which is known as EMCP. I'm coming to that. I will come to that. World Bank. I agree, and I totally understand why are you asking this question, because this was one asked in entrance exam. when they ask you regarding EMCP. So I'm writing that program also for you. EMCP. EMCP is enhanced malaria control. Rollback malaria is separate beta. It was not under rollback, is not under MPO. MPO was very early. Rollback malaria was in 80s when it was launched. Then it was launched another program which was enhanced malaria control program. EMCP, enhanced malaria control project, rather we should call it as. Now this is very important, that this is a World Bank funded project. World Bank funded project. This was asked in your entrance exam, that which is the World Bank funded project. It is EMCP, or enhanced malaria control project. Now what it is saying, it is running for 1045 PHCs in 100 districts of 8 states. For 1045 PHCs in 100 districts of 8 states, this World Bank project is been running. Now they ask, what is the selection criteria? Selection criteria for PHC. What was the selection criteria for PHC? And that we should remember, it was where API is more than 2 in last 3 years. PF cases more than 30% of all malaria cases. And out of all malaria cases which this PHC is reporting, more than 30% should be of Plasmodium falciparum. This is the second criteria. The third criteria was 25% of population should be tribal. 25% of the population should be tribal. And fourth one is area reporting deaths due to malaria. So any area which is reporting deaths due to malaria should also be included under EMCP. And what is EMCP? Nothing else. Again the same thing which I told you earlier, the same program, but it should be enhanced, just enhanced malaria control project. So that is something that they have to have religious activities or very activities which should be done in a deep manner in these 4 areas which fall into this category. So that is something which is important for you. Okay, then there is a question that in malaria, which is the most sensitive index? Most sensitive index for should all be there. No beta, Mysore, or, that was or. It was or. It was not and. So most sensitive index for recent transmission of malaria. Most sensitive index for recent transmission of malaria is infant parasite rate. So it is most sensitive index. Then they ask you what is the operational index. Operational index, very good Mysore. It is ABER, annual blood examination rate, which should always be more than 10%. So that is something which is known as operational index. Recent transmission, infant parasite. Operational index, ABR, annual blood examination rate. An annual blood examination rate should always be more than equal to 10%. Then the third one. And then they ask you a very important concept. And then they say that, can you tell us about the risk stratification? Risk stratification means When we say risk stratification, it means low risk areas and high risk areas. Low risk areas and high risk areas is known as risk stratification. So this risk stratification in rural areas is done with the help of API or annual parasite incidence. But when they say the same thing is to be done in urban areas, it should be with the help of another index which is known as SPR or slide positivity rate. So API is for rural and SPR or slide positivity rate is for urban. So that is again very important. Okay, so that was from the section of malaria, but it cannot end if we say that which type of malaria is caused by which. Okay, and that is which type of malaria by which anopheles. Please repeat first 2 minutes of malaria. Beta, I didn't remember Allahabad, but that was regarding just this. You were saying the initial first 2 minutes. So that was just about, okay, Allahabad, but that was just, we talked about that this malaria, we were talking about MPO. So we started with MPO in 1977. Yes. MPO was launched. Okay. Most common epidemiological type of malaria, Plasmodium. Okay. No, that is important, that nowadays the problem lies that we have this P. vivax and P. falciparum, and now we are having this, that falciparum is crossing India. Allahabad, what you told about 1977 was 1977 MPO was launched. Okay, so falciparum is said to be more common. You are saying about novoc. It is Dule, you are asking about what? Plasmodium novoc what? Because that's more a biologic question which you are asking. Because if you ask me that presently in India, we say that falciparum is crossing. Otherwise, we have been teaching it for a long that Vivax, and even in previous batches of the same year, we say that yes, that Vivax is the most common, malaria in India. But nowadays, falciparum is also crossing very fast. Okay. Then they say most common epidemiological type or malaria, indices of malaria. I'm not getting your question, Mysore, though we'll take it at the end, but I'm not getting indices of malaria and epidemiological type. What do you want to know? Okay, spleen rate, no, it's not being used beta now. Spleen rate and all, they were used when the parasitological indicators were not there. You know, these are known as pre-eradication and post-eradication. So now we are having all those. So now no spleen rate or anything is used now. No clinical. It's all parasitological indicators which are being used. Okay. Now the last from the malaria section is, I am writing it and then you should know what exactly it means. Like we say that if it is Anopheles culissifaces. Oh, I'm writing it there because that is which type of malaria is spread by which mosquito type, because these are asked very many times. Okay, so it is Anopheles culissifaces. It is rural malaria. Anopheles culissifaces, rural malaria. It means which type of malaria is by which Anopheles type. Okay, so Anopheles culissifaces, yes, culissifaces. Anopheles culissifaces, rural malaria. Anopheles stephensii, urban malaria. Rural malaria, urban malaria. So stephensii is urban, not Kolhapur, hilly not. Stephensii is urban rather. Then Anopheles fluviatilis. Anopheles fluviatilis, it is foothills. Anopheles sundicus. Anopheles sundicus, it is brackish water. Brackish water means salt water. Brackish water, Anopheles sandicus. Then there is Anopheles sandicus. Then there is Anopheles dirus. Anopheles dirus. And Anopheles dirus is foothills of northeastern states of India. Then Anopheles minimus, northeastern states of India. You know, again there is a question that coastal malaria is spread by which Anopheles type, and you should remember that that is again Anopheles stephensii, which is causing coastal malaria. Coastal malaria. Anyway, so that is all from the section of malaria, because we have done enough from the malaria section. Now let us take the third disease and then we'll move ahead with the non-communicable portion. But that is very important for you because we have talked about the drug policies. We have talked about malaria and its drug policies. That is very important, and that was separately, covered. Now let us take what are the questions which are asked from the filaria or filariasis. These all I told you earlier also that we are reading or studying about all these diseases at length because of the problem that now this year is being dedicated to vector-borne diseases. Otherwise we do not have that much elaborate discussion on filariasis or assessment of how this filariasis is being assessed. But anyway, as I told you that this is very important. Now let us come directly to assessment of filarial control program. Assessment of filarial control program. And this is very important for your entrance exam because maximum questions are asked from programs from these these vector-borne diseases. These all vector-borne diseases are under NVBDCP program, you all agree, and I'm now telling you specific portions of individual diseases which are under NVBDCP. So you all know that the very important questions which they ask is about microfilaria rate. And what is a MF rate or microfilarial rate in filariasis is percentage of patients showing microfilaria in blood. It can be population also, percentage of population. You will say that this many number of population or percentage of population is showing microfilaria in their blood. So that is something which is known as MF rate or microfilarial rate. The second one is most important, and that is filarial endemicity rate. Filarial endemicity rate. And what is filarial endemicity rate? We all know it is percentage of population showing microfilaria in blood. Percentage of population showing microfilaria in blood or manifestations or both. So you may understand that this is the most commonly used criteria for getting information about the filarial problem. So that is something which we know, which we call it as filarial endemicity rate. So percentage of population showing microfilaria in blood or manifestations or both. The third one is known as microfilarial density. Microfilarial density, and that is number of microfilaria per unit volume of blood. Number of microfilaria per unit volume of blood, and that blood is actually 20 millimeter cube of blood. So when we have taken 20 mm cube of blood, so what is the number of microfilaria per unit, and that you can understand, that is the density. So what it tells us about आपका PGI in Chandigarh question, that it tells us about intensity of infection. It tells us about intensity of infection. So intensity of infection is by microfilarial density rate. Then we have next in the same, because there are lot many indicators which are being used in microfilarial, and that is average infestation rate. Average infestation rate, and average infestation rate means average number of microfilaria per positive slide. Average number of microfilaria per positive slide. And what it tells us, it tells us about prevalence of microfilaremia. It tells us about prevalence of microfilaremia, because it tells us average number of microfilaria per positive slide, which is very important for us to understand. Then there are some entomological criteria also. Entomological criterias, and when we say entomological criterias, you should understand that there is number one which is very important, and that is vector density per 10-hour men catch. You all know in your entomological classes it has been told to you in your undergraduate years that when we say that in 10 years a man is able to catch how many insects or vectors or mosquitoes, that is entomological criteria. The second one is percentage of mosquitoes with third stage infective larvae. So how many number of mosquitoes or percentage of mosquitoes are with third stage infected larvae, that is something which is there. You are saying by 2015, is it scientific? What scientific? Entomological criteria, Mysore. Yes, it's scientific. Yes. Why are you saying it's not scientific? It's entomology. Doctors, they man catch. Yes, men are catch. That tells us about the density. Yes, that we take. That still we do, beta. That we still do, but we don't expect you or us to do it. It's entomology people, they used to catch it. That's just one criteria. That's not the only one. And it helps us. There are a lot many criteria. Annual biting rate. And for you, more important is that you should know it for your entrance exam. Mysore. You should understand this way only. And last is the type of larval breeding places. Larval breeding places. So that was larval breeding places. If we go with these are some of the entomological criteria which are being used. And that is very important. Believe me, that these kind of questions, when they come in entrance exam, they make us feel bad because sometimes we miss all these kind of questions. But these are very many time asked questions in your setup or in your entrance exams. So last in the order for these diseases are sandfly, and that is the very important vector this year, and we'll end the vector diseases with sandfly. So what are the questions which are asked from sandfly? As we all agree, the disease which they spread is Kala Azar. So what are the questions which are from Kala Azar this year? We all know that because Kala Azar is taught very religiously in medical schools in India, what we say, just a brief write up on Kala Azar. If it is visceral Kala Azar, visceral leishmaniasis rather, visceral leishmaniasis, the other name for this is known as Kala Azar. And the agent which is used, which is known to cause this visceral leishmaniasis is Leishmania donovani. And then they are going to ask you that what is the vector. We know vector is Phlebotomus argentipus. So the first thing which we used to teach you in your graduate classes or undergraduate classes is visceral leishmaniasis. The agent is Leishmania donovani and the vector is Phlebotomus argentipus. Then the second in the order is cutaneous leishmaniasis. Cutaneous leishmaniasis, and cutaneous leishmaniasis is also known as oriental sore. Oriental sore, and the agent which is used for this is known as Leishmania tropica. Leishmania tropica, and it is Phlebotomus pipetzii or Phlebotomus serpentii or serpentii. So Phlebotomus pipetzii and Phlebotomus serpentii. So Phlebotomus serpentii, Phlebotomus pipetzii. The third one in the order is mucocutaneous leishmaniasis. Leishmaniasis, and these are Leishmania brasiliensis. Leishmania brasiliensis, and this Leishmania brasiliensis is again caused by Phlebotomus pipetzii and Phlebotomus serpentii. So what these are very important few things which you need to remember, and these are mucocutaneous leishmaniasis, which is Leishmania brasiliensis, Phlebotomus pipetzii and Phlebotomus serpentii. Then the question is asked, and then they ask you regarding the incubation period in cases of Kala Azar. And when it is asked, the incubation period in cases of Kala Azar is 10 days to 2 years. And we know the average age which is affected for children is 5 to 9 years. So 5 to 9 years children are most affected by Kala Azar. Then what are the questions? Again, as I told you, that the questions are mostly on, the things which they ask is that in Kala Azar, the which drug is known as the wonder drug. Wonder drug in Kala Azar, and you all know that wonder drug in Kala Azar is miltefosine. So one question is this, when they ask you regarding that which drug is known as wonder drug in Kala Azar, it is miltefosine. Then they do ask you another important question, and that is that aldehyde test, which you have learned in your microbiology section, is a test for, always say, surveillance. Aldehyde test is a test. One drug is miltefosine. Aldehyde test is surveillance, is done for surveillance. So aldehyde test is done for surveillance test. And then there is leishmanine test. Leishmanine test, or which is also known as leishmanine test of Montenegro. Leishmanine test of Montenegro, yes, that is used for immunity status checking. Immunity status, or which we also known as, we call it as for susceptibility. For checking the susceptibility, we are using leishmanine test, or we are using leishmanine test of Montenegro, while the aldehyde test is used for the purpose of getting surveillance work done. Okay, so now as I told you earlier that the things have been done and the vectors are there, and we have covered many vectors in this portion. Now let us come to the questions which are coming from the other diseases, and in that order, the thing which is left, because we have already talked about the treatment part for tuberculosis, but the thing which is asked or which is left now is some of the questions which were asked from RNTCP program, or the questions which were there from that section. So now we'll cover those portion in a very, is there IV drug for leishman? No, actually it depends now what kind of question you are getting. Okay, discussion paper yet not received, sir. Bilaspur. Okay, so I'm also getting thing. Bilaspur is not yet. Belgaum, sir. Few important points about Ebola. Oh, but not completed till now. Jammu, multifocin is IV. Yes, Agra, same here. So there are a lot of queries which are coming up that you are not getting your discussion paper. That's not covered in discussion paper. So what we'll try is, first of all, so don't get anxious about all these things. I got it that you are not having your discussion paper with you, but let us first of all try to cover up things which we are intending to cover. Okay, now, and then we'll discuss that what are the things which are not yet covered. Bilaspur, your paper is being mailed. Okay, and very many centers have been mailed those discussion papers, because that I agree that you were not having those papers. But let us discuss first the things which can be covered. Because we should not forget that just 1.5 hours is left for your next class. If, believe me, if there is anything which can be extended, we'll try to request the coordinators. Okay, Agroha is also mailed. I believe Agroha is also mailed. Okay, now first of all, what are the questions on RNTCP? Just those questions which are asked and which are very important, which you should remember. The already things which you already know, will not discuss those important thing. Now first question is, single patient can infect 10 or more people in a year. Single patient can infect 10 or more in a year. That is something which is important. Number one. Number two, it is a very important thing which you know, and just a revision of that more than equal to 70% detection is required, while more than equal to 85% of cure rate is required. This was earlier also. Third, very important part, that in RNTCP we say that the dots is the strategy which is being used. So we say components of dots, and these are just 5, just a revision of that, and that is quality, microscopy, and quality detection. So this can be there, words can be there, that quality microscopy can be there, should be there. Number 2 is uninterrupted drugs, uninterrupted drug supply. The third one is monitoring and evaluation, M&E. Fourth one is DOTS itself. And last is political will. So this was the third part. So component of DOTS are quality microscopy, uninterrupted drug supply, monitoring and evaluation, that means M&E, DOTS, and political will, which is important. Then next very important question which is asked in your entrance exam is that 1 TB unit is for 5 lakh population. One TB unit is for 5 lakh population. Then the second one is one dot center is for 1 lakh population. So for 5 lakh population, 1 TB unit is there. For one dot center, 1 lakh population is being assigned. Sixth is one designated microscopic center, DMC. Designated microscopy center or DMC, 1 lakh again. So 1 lakh is for designated microscopy center, dot center 1 lakh, TB unit 5 lakh. Then there is one STLS, that means senior TB lab supervisor. One senior TB lab supervisor or one STLS should be for 1 lakh population. Oh sorry, 1 TB is for 5 lakh population, 5 lakh. One STLS is for 5 lakh population, or you can say he is in charge of 5 DMCs. These are all your entrance exam question, that when we say one STLS or one senior TB lab supervisor, he looks for 5 lakh population and he is in charge of 5 DMCs. Then there is again a question that when we go for having all those that we remember what are new cases, what are default, what are all those important questions, then what are the epidemiological markers? Epidemiological markers for tuberculosis. And always remember, the first and the very important marker which is used for as an epidemiological marker for tuberculosis is, which is known as ARI, which we call as annual risk of infection. This ARI, or very good Mysore, this is also known as, we call it as the tuberculin conversion index. Tuberculin conversion index or TCI. Always remember, 1% rise in TCI means 50 sputum smear positive cases per lakh of population. So when we say 1% rise in TCI, when we say 1% rise in TCI, it means 50 sputum smear positive cases per 1 lakh of population. Presently, India have TCI 1.5%. So presently in India we have TCI or tuberculin conversion index as 1.5%, and that is where we say that in India around 75 sputum smear positive cases are there per 1 lakh of population. So you can get that figure very easily from this, that this is because of this we say that 50 plus 25, that means 75 sputum smear positive cases are residing. Another very important is that is prevalence of infection. Prevalence of infection. Prevalence of infection, and prevalence of infection is by tuberculin positive test or tuberculin positive. So tuberculin positive is presently in India 30% overall. So overall is 30%. So tuberculin prevalence of infection is 30%. The third one is prevalence of disease. Prevalence of disease, and that is 14 to 26 per 1000 population. Because always remember, ARI or annual risk of infection was incidence of disease, but when we say prevalence of disease, it is 14 to 26 per 1000 population. So that was from the section of getting this RNTCP question. The guidelines. So it is measured by prevalence of disease, again is measured by sputum. It is by sputum, sputum smears. So prevalence is not measured by those as we were measuring incidence. Incidence was being measured with a surrogate marker of ARI or annual risk of infection, but sputum smears, with the help of this we take this prevalence of disease. Can wife of an affected case act as a DOTS provider? Yes, she can act as a DOTS provider. That's very true. Yes, she can act. Jammu. Okay. Now the last in the section of programs, which we have, because now we are dealing with programs, is that then what is the difference between the prevalence of infection and prevalence? That what's the difference between infection, because both use sputum smear. No beta, Mysore, always remember, when we are saying incidence of disease, we were not using this, we were using again tuberculin test. For incidence we were using tuberculin. Try to understand where what we were saying, the annual risk of infection is tuberculin conversion, so Mysore, I believe you are able to understand that in this incidence of disease, it was measured by tuberculin positive. So tuberculin conversion of tuberculin. Okay, sincere request. Oh yes, we all understand this. Now NACP, National AIDS Control Program, NACP 3. Now already very important that NACP 3 is National AIDS Control Program, and you should remember this is the last program, and then we'll take miscellaneous portions first. That National AIDS Control Program 4 is going to be launched. So maybe by your exam it is launched, but I believe because your exam is already announced on 1st to 6th December, so before that NACP 4 is not likely to come. So what are the findings of NACP 3 which we should know for getting NACP 3 done? Number one, it is that it is a targeted intervention approach. Targeted intervention approach. Targeted intervention approach. And when I say targeted intervention or TI approach, then the question is asked that what is TI? TI are bridge population. Bridge population. So what is bridge population? Bridge population means like truckers. So what you need to remember is like truckers. So truckers are bridge population, and there the targeted intervention approach is being used. So now target is on this population. Why these bridge are addressed? Because this disease changes from high risk or HRGs, high risk groups, to LRGs, low risk groups. Because now the disease has changed from HRGs to LRGs. So government says that now it's the time to look for these bridge population. The second one, which is very important for us to understand, is that NACP changes from IEC to again BCC concept. They say that BCC is very important. The same thing which we know about RCH, that they say that BCC or behavior change communication is very important part, and they say it is to be done very important way. Third, NACP 3 say decentralization of NACO. They say that NACO should be decentralized. NACO should be decentralized, and it should be NACO or NACO at the Delhi level. Then there is SEC at the state level. SEC is what? State AIDS Control Societies. State AIDS Control Societies are known as SECs or SACS, State AIDS Control Societies. And at the district level, there is DACU or DAPCU. DACU is District AIDS Control Units or District AIDS Prevention and Control Units. So DACU or DAPCU. So these are there. So DACU, DAPCU. So that was decentralization of NACO, which was done. Then there was fourth very important step, OST. This is known as oral substitution therapy. So for all intravenous drug users, because intravenous drug users are using some mode of addiction, so they've been asked to use OST or oral substitution therapy by government. So that is known as OST. Then fifth is strengthening of ICTC. You all know what is ICTC, Integrated Counseling and Testing Centers. So these are strengthened by the government in NACP 3. 6 is post-exposure prophylaxis for persons at risk. Persons at risk. So we all doctors, we should have PEP now. So post-exposure prophylaxis, PEP, for persons at risk, like for us, PEP should be given, post-exposure prophylaxis. 7th is STI treatment and barrier methods promotion. So STI treatment and barrier method promotion should be done, and it should be used. So what government says. Now, so these are some of the bullet points of of NACP 3. Rest of the points you may get, these all hi-fi words, that the monitoring should be there, the quality should be maintained. All these are there in each and every program. So no need to get worried about all those concepts. Now there is a question in entrance exam that you remember NACP 2. It, divides an entire country into three parts. And when it divides the entire country into 3 parts, it was, we call it as high prevalence states, moderate prevalence states, and low prevalence states. We divided into these 3 parts at NACP 2 time, and it is asked in your entrance exam that it is based on the prevalence of HIV in commercial sexual workers or MSMs. And the second one is it is ANC attendees or antenatal clinics attendees. Now high prevalence states were those where it is more than 5% and more than 1%. Moderate prevalence was more than 5% and less than 1%. And it is less than 5% and less than 1%. So they usually ask you, that if this is the criteria of division of country into three prevalence zones, that first is high prevalence, the second one is moderate prevalence, and the third one is low prevalence, then these states were known as GGP states, or Gujarat, Goa, Pondicherry. The low prevalence states are all low performing states plus Delhi. So all low performing states who perform low at each and every level in health, fortunately they also performed very bad in HIV, and that is an advantage. Now when we say this, these are those states which are high performing everywhere, but unfortunately they performed high in HIV also. So these were all Tamil Nadu, then there is Arunachal Pradesh, then there is these all states which were there. So they are here, even Maharashtra is here. So all these were the high prevalence states where it was done. Now they ask you that this kind of prevalence which you got, JK also, yes, these are known as a way which is known as, we call it as, because here these samples are taken and this surveillance is done, it is known as sentinel surveillance. So this whole thing, or this whole information which we gathered it with the help of sentinel surveillance, which is a very important surveillance system for getting true prevalence of HIV. Now what the next question is asked in your entrance exam is that for sentinel surveillance, how many units are made? And always remember, for sentinel surveillance, 3 units are made again. You should say one is of CSWs and MSMs, the other is of ID or intradermal use, and the third one is ID and VD clinics. And the third one, or third, VD clinics means venereal disease clinics, dermatological clinics, and the third category which we used was ANC attendees. So what you need to remember is that from CSW or MSMs, a sample of 250 is taken, from here again 250 is taken, and from here we take a sample of 400. So this is what is asked in your entrance exam. VD, venereal disease clinics, that means skin clinics, skin. So venereal disease clinic is there. So VD is for STI. So 250 is taken from CSW, 250 is taken sample from IDVD. This ID is intradermal users, and venereal disease. Sometimes they place this ID here also, but in few of the guides it is written that ID should be from this category, and venereal disease clinics and ANC attendees. So it is 250 sample and 400 sample is taken. Now this entire thing, now I'll tell you, is known as anonymous unlinked survey. Yes, Aligarh is asking MSM. Allahabad has replied it. Male, sex, male. Jammu, MSM. Beta, MSM is a very, it's not that we have made this word. This word is being made by all policy makers, because nowadays in India, apart from commercial sexual workers, male sexual workers are very many in India. And because of the problem of homosexuality which is occurring, we should not call it as a problem because it's the sexual orientation. They sometimes have these sexual workers also. So we call them as MSMs, or male, sex, male. So then anonymous unlinked survey. Now this anonymous unlinked survey, this is very important, which I need to tell you. This is anonymous. We never know that the name of the patient. We cannot even tell him or her that he or she is getting positive. So if he or she is getting positive HIV status, we cannot inform him or her. So that is something which you need to remember, that this is anonymous unlinked survey. This is very important for you to remember. Now, as we are dealing with the questions from the HIV section, there is again a very important thing, that when it comes to the counseling, or when it comes to, rather we should say, the testing or laboratory testing of for HIV patients, we have two criterias. They are saying, Jammu, how would treat if you don't inform? We don't treat them. It is Jammu, we don't treat them. It's just for surveillance. There is a question in entrance exam. If you go by a guide, they will ask you that anonymous unlinked surveys are meant for answer for getting surveillance work done, for getting data about any disease. So we are concerned more to get the information. We are not concerned about their status. It is an unlinked anonymous survey. So the purpose is different, so we don't treat them accordingly. Okay. So if we take, I'll tell you where you are going to treat them. This is testing for HIV. It is done for two ways. One is known as, what we call it as, opt-in, and the other one is known as opt-out. Opt-in and opt-out. So what is opt-in? Opt-in is for ICTC. It is voluntary. So if somebody asks you that, what is opt-in? You should say that means when somebody himself or herself comes to your chamber and then they say that, can we opt in? We would like to have our blood test done to get an idea whether we are afflicted with HIV or not. So that is something which is known as opt-in, ICTC, voluntary. So it is in India. There is a pre and post test counseling. But if they say opt out, always remember opt out is for pregnancy. Yes, very good. Pregnancy. Then there is major surgeries. And even for tuberculosis, you can ask opt out. Opt out means here patient is informed by doctor that he or she needs to get his or her blood examined to get an idea that whether she or he is suffering from any kind of HIV problem. And if it is so, then something needs to be done. So that is very important for you to get an idea. So that was from the section of, HIV, where the questions are asked from NACP or NACP 2 or NACP 3. In NACP 2 there was again a question which was very famous at my time, and that was 3 by 5. 3 by 5. So what was 3 by 5? You all know 3 by 5 means by 2005 3 million people, 3 million people, we call it as PLHA. Or PLWHA. What is people living with? We also call them as PLWHA. If this is a word, that means people living with HIV and AIDS. So they say by 2005, 3 million PLHA or PLWHA should get ART or antiretroviral therapy. Now this 3 by 5 is increased now. So earlier at my time we used to take this answer, but now still it is there in your entrance exam, but it's an old question which says that by 2005 3 million people living with HIV and AIDS should get an access to ART. Because now we are living in 2014, now government says that every PLHWA or PLWHA or PLHA should have the right of having ART, accessibility to ART. Belgavi Singh sir, in opt-out, can the patient reject HIV testing? Yes, he can. That means you should also remember that in opt-out also we should go for pre and post test counseling. If suppose the patient says no, we are not ready to take this test, we would not go for this testing, then you can't do anything, because it is always where it is as per the wish of patient. At that time you may say that okay, then there are risks of getting HIV and I would not like to operate your case in a different way, because we cannot there is always legal implications to that. Okay, so that is very important. Now Mesur is asking, baby is separated from mother, who is positive for how many hours after birth? No, it's not after how many hour after birth. It is said that initially in tuberculosis it is immediately the conversion occurs, but till 48 hours nothing should be, there is absolute contraindication, but they say that it should be for 4 to 5 days if you say, but if the question is asked in your entrance exam, it should be 48 hours. That means 2 to 3 days only. 48 hours, or that's what I'm saying, because in most of the books it is written 1 week. So it's better if 48 hours is then the option, it is 48 hours, because in India we follow this 48 hours, but rest of the countries say it is for 1 week. So for India it's better to say it's 48 hours, because in India he or the baby will suffer from problem of this, for TB, not for HIV. HIV, the separation is a must, there is no breastfeeding allowed. In India we say either, I'll tell you, if there is a question for TB or HIV, TB we have already said, I'll tell you which they are asking. For HIV, if it is for HIV, it is, we say exclusive breastfeeding. For HIV, if it is an HIV infected mother, it should be either exclusive breastfeeding or exclusive top feeding, or is very important, and that is we started immediately. If suppose there is a person, or this nevirapine syrup is given to the child immediately for 6 months, that person is this. Okay, Gulbarga sir, class beta by 2, because from 2 you will have the different this. Okay, no change. Okay, now let us come to another. No change. Lunch break is on at 2. Lunch break is at 2, I believe. Bilaspur lunch break is, I believe, is at 2. Okay, now let us get to another very important thing, because now we have done with most of the thing. Bilaspur class, then I'm not understanding what you're asking there. You're asking about class, you're asking about break, or you're asking about till what time I'm here. I'm here till 2, because I've been told that the class should be from 9 to 2 for community. Okay. No idea for next class, because you are not having those question papers with you. We'll start at 2. Okay, but first of all, let us talk about something, about the different. Now we have come up to different portion, and now I'll try to come up to non-communicable important questions which are there. Free of cost under any national program. Yes, nevirapine is given. Nevirapine is given free of cost by Government of India now under NACP 3. Now the question is on what are the questions are which are very important for you, Beta, now you are asking so many questions. You are saying now when to say TB is resistance. Beta, when we say resistant, it is always when we get this information through sensitivity testing that the patient is, or the sputum is not sensitive to INH as well as rifampicin, and that can only be with the help of testing. Okay, so doubts, so there are a lot of many doubts, but its resistance 5 months. When you say this resistance in 5 months, that is failure. Mysore at 5 months it is failure, not the resistant. Resistant has got sensitivity testing. Failure is at 5 months, he is positive. Okay, now let us talk about some of the diseases which are very important, not for your practice, but for the thing which we say for the entrance exams. And then in that, the very first thing which is there is the program which is being run by Government of India, and that program is known as the National Program on Non-Communicable Diseases. But for that, let us talk about few things which are important, and those things are the first which they are asking are about cancers. So now what are the questions which are there on the cancers? Now let us take one by one. Most common cancer, India, in males, it is oral. So no change, because there are a lot many confusions which are being there in your Facebook. But please ignore those confusions. Most common cancer, India, females, cervix. But when they say that it is urban, it is breast. Then they say that, yes, then they say maximum mortality. And when they say maximum mortality, it is something which is lung. Then they say very important thing that there is a cancer registry program in India. Cancer registry program. And when there is a cancer registry program in India, it is rural and urban. This is population based cancer registry program. So when we say population based cancer registry program, these are Delhi, Mumbai, Chennai. Delhi, Mumbai, Chennai. Then we have Bhopal and Bangalore. So Delhi, Mumbai, Chennai, Bhopal and Bangalore are the cancer registry programs in India in urban areas. But when it comes to rural areas, then in rural areas it is just Maharashtra. So Barshi or Maharashtra is the place where we say that the only cancer registry program is there. Then the program which is being run by Government of India under this is being launched and I believe I've already shown you the slide of that program, how it looks. That is actually known as NPCDCS. The program which is being run by government is I'll tell you. There is just single program you should always remember, which is run by Government of India, that is known as NPCDCS. NPCDCS program. That is known as National Program for Prevention and Control of Cancer, Cardiovascular Diseases, and Stroke. So the program which is being run by Government of India for this purpose is National Program for Prevention and Control of Cancers, Cardiovascular Diseases and Stroke. Now what do I want to tell you about is, because that's the only program which is running for all these things in totality, then they ask you that this cancer is looked after at which level. What you should remember for this program, and that will cover this program for you for your entrance exam also, make a small triangle and you will get the information. This is what you need to make. Just make a small triangle and then here write subcenter. The first level is subcenter, the second level is CHC, the third level is district hospital, and the fourth level is tertiary center or medical college. So what you need to remember is that at sub-center screening facility is there. screening facilities there at sub center. And always remember, it is handled by VHC. What is VHC? Village Health Committee. So Village Health Committee, it takes overall charge of screening facility which is there at sub center. Village Health Committee is looking after sub center. Then there is CHC. At CHC there is NCD clinic. NCD is non-communicable disease clinic. So NCD is non-communicable disease clinic and it is at CHC, and it is actually Rogi Kalyan Samiti. Rogi Kalyan Samiti. So this is CHC. So at sub center there is VHC or Village Health Committee. At CHC, NCD clinic, Rogi Kalyan Samiti is there, where NCD clinic is kept. Now comes our question. At district hospital there is NCD clinic, cardiac care unit, CCU, cardiac care unit, and cancer care facility. So these are the question. When you go by your guides, you will find this question in your entrance exam, that the first cancer means treatment for cancer can be made available at which level. And always remember, this is district level. Or you can say, if there is a patient which is being detected by screening, a person detected by screening facility at sub center or CHC, then he or she should be referred immediately to district level, because there is a cancer care facility or CCF. And at district level it is under control of district NCD cell. District NCD cell. So district NCD cell is looking after this. And at the tertiary level there is medical college, and this medical college is taking all care of all cases. So no referral from here. So medical is the topmost. It is state NCD cell. State NCD cell. So state NCD cell is at the highest level. So here there is tertiary level or tertiary center is available. Now this entire thing, because there was a question which was once posted in Facebook by some student, and he said that at PHC, primary health center, the cervical screening for the screening for cervical cancer is done by, and there was an answer which was posted that it was by pap smear. No, always remember, it is under IPHS or Indian Public Health Standards, where they say that pap smear should be made available. But believe me, and you have also seen in PHCs that only in few PHCs pap smear is available. So it's always clinical or visual inspection with all those agents, or so that is rather the option which is available in your entrance exam, where they say clinical is the way of screening at PHC, which is a better answer in comparison to the pap smear. Though IPHS say it should be, but it's not available. So it's always better that we should take clinical as the way of having this facility done. Then there comes the question, this was from the section of cancers and the related programs, which is this NPCDCS. Now nowadays very many time questions are asked from the category of obesity, and when they say the category of obesity, the problem lies that in obesity we have very many criterias which are available, and that is even for BMI the criteria is different for India and for rest of the world. But what are those? We'll go by those criterias. But before doing that, now let us talk about what is the WHO criteria. And the WHO criteria for obesity, for when we are taking into consideration the BMI, is normal 18.5 to 24.99. When we say overweight, it is more than equal to 25. When we say obese, then in that they say pre-obese, obese class 1, obese class 2 and obese class 3. So how we remember it is that we just remember the lower part. So we say 25 more than equal to 25 is this. Then pre-obese, because that is the one criteria which we have for overweight. So what is normal? Normal is 18.5 to 24.9. So when we say overweight, overweight is having all these criteria within them, because overweight is anything which is above 25. So what is pre-obese? 25. You write like here 25, 30, 35, 40. Only write this much. Okay, so when we say pre-obese, 25, 30, 35, 40. So we can understand it very well. 25 to 29.99, 30 to 34.99, 35 to 39.99. So it is always better not to write these things, only remember these things. If you remember this thing, the right side will be made by your own. So 25, 30, 35, 40 is the pre-obese, obese 1, 2, 3. As somebody is asking what is morbid obesity, more than 40 is morbid obesity as per BMI criteria. Then if this somebody is asking about thinness, then thinness is grade 1, it is 17, grade 2, 16 and grade 3 less than 16. So you can make it that 17 to 18.49, 16 to 16.99. So again, there is no need of writing it, but yes, you may write 17, 16 less than 16. This is known as thinness. So BMI, so we know, we've been doing it for a long time. What is BMI? Now the question arises that for Indian scenario or for Asian population, what is that? Very many books are writing different for Asia, different for India, but you should remember just one, an easy way to remember. For Asians, less than 18.5 is underweight. If it is 18.5 to 23, it is normal. 23 to 27.5 is pre-obese. And more than 27.5 is obese. And you know, the only difference for Indians is, if say Indians, they say that here they write as 24.99 and more than equal to 25 they call it as obese. So that is all. That is sometimes given in few books that okay, there is a little different criteria, you know. So that is there. So that is obese, pre-obese. So that is a bit different, and in few books it has been written that it is 23 to 24.99. 23 to 24.99 is pre-obese, and then they say it is, or that in some of the books it is also written as overweight. And this is obese. In India also, like we say, it is for more than equal to 32.5. In India, bariatric surgery is needed. Bariatric surgery needed. So bariatric surgery is needed. That means in India we can call that more than 32.5 is morbid obesity, because here even if somebody is having 32.5 and above, he or she may request for this bariatric surgery operations. Okay, then we have so many criterias for obesity, and I'll tell you there are very many questions which are asked in your entrance exam, and one such is ponderal index. Ponderal. And ponderal index is weight in kg upon height in cube. It is in meters. Height in kg, weight in kg, and height in cube in meters. It is Ponderal index. Then we do have another, and that is Broca's index. That is height in centimeters minus 100. Height in centimeters minus 100. Please refresh. Okay. Gorakhpur is saying refresh notepad. I will. Now the question is asked that what is Lorentz formula? Lorentz. Gorakhpur, if it is visible, Lorentz formula. Gorakhpur, if it is visible, I hope Gorakhpur is getting all those images. Lorentz formula. And Lorentz formula says height in centimeter minus 100 minus height in centimeter minus 150 upon height in centimeter minus 100 minus height in centimeter minus 150 upon 2 for women, and for men it is height in centimeters minus 100 minus height in centimeters minus 150 upon 4. It is for men. So what is the formula? Formula is a bit, those who have used it in community, they know, but otherwise those who have not used it, they know. They should get it clear that for females it is height minus 100 minus height minus 150 upon 2, and for males it is height minus 100 minus height in centimeters minus 50 upon 4. Then there is corpulence. We know corpulence index. Corpulence index. And corpulence index says ponderal index. Hubli. Ponderal we have already told you, beta. Height in, okay, I'll write it again for you. But for first, corpulence index. Corpulence index is equals to actual weight upon desirable weight. Actual weight upon desirable weight. So corpulence index is equals to actual weight upon desirable weight, and it should not increase, it should not increase, or it should not exceed, not increase, it should not exceed 1.2. So when we say corpulence index, always remember corpulence index is where it is equal to actual weight upon desirable weight, and it should not exceed 1.2. That is must, we should remember. Somebody was asking again that what is a ponderal index. As it was written earlier also, but yes, I'll write it again for you, Hubli. Ponderal index means height. Okay, there are two formulas, that is why you got confused. One is height in inches upon cube root of body weight in pounds. One is this. Or if you say that we'll take in kg, you will say then weight in kg upon height in cube, and that is in meters. So these are two formulas which should be known, that sometimes they change. When you change the SI units, the numerator and denominator also changes, it reverses. So ponderal index is height in inches upon cube root of body weight, and that is in pounds, or weight in kg upon height in cube. that is in meters. So that is Fondel index, which is important for you. Okay. First one for child. Which one? First one you are saying? This pounds. Yes, you can use it because usually for children we use pounds and inches. Yes, we can use. Yes, yes, yes. It's what this Hubli normal is 2, but by above formula it's 20 pound. BMI same as Quetelet. Yes, Jammu, you are absolutely true. BMI or body mass index is also known as Quetelet index. You know, Hubli, you go by this formula because these formulas are, you know, by derivations. So we'll discuss that if we get the time, but the time is very less. But these are the exact formula. You don't worry, Hubli, because these are what you need to remember. Okay, because now still there are something which are left, and that is Herpenden calipers. Herpenden calipers. If you use Herpenden calipers, then skin fold thickness is noted. Skin fold thickness. And this skin fold thickness is, yes, very good. It is at, you remember your gyms, you must be in a good gym like Talwalkar's gym or Bob gyms. All those gyms, the instructors, they used to take your obesity with the help of these Herpenden calipers. And what are these? These are mid triceps, biceps, and subscapular and suprailiac. Skin fold thicknesses, 3 areas: mid triceps, mid biceps, suprascapular, and the fourth one is suprailiac. So what you need to remember is, when we add them together, total sum, we add them together, total sum, if it is exceeding more than 50 mm in females or more than 40 mm in males, it is obesity. So in India we say that if it is more than equal to 50 mm in females and more than equal to 40 mm in males, it indicates obesity. Then there is waist hip ratio. Waist hip ratio. And presenter, please start radio class after 2:30. We need lunch break. I have asked the coordinators, bacho. Waist hip ratio. Waist hip ratio. Okay, let us see. है ना, waist hip ratio, first of all बेटा पहले इसको लिखो. Waist hip ratio is, it is more than 1 in males and more than 0.85 in females. More than 1 in males and more than 0.85 in females. Okay, Davangere, I agree totally that you have not yet received your question paper. So what we can do is that we'll ask the coordinator to have one more class of 2-3 hours duration. In that we'll try to discuss the question papers, because I agree, because question papers are not being given to the batches, so they are left with no question papers. And I believe question papers are very important because that gives a greater coverage to the entire subject. So I'll ask the coordinator, she's not available today, I'll ask her when she's back that whenever she gives this paper, do give me a call for 2 hours or 3 hours so that we can discuss questions and questions, and then we'll discuss all those things. Okay, so it is waist hip ratio. So it is more than 1 in males and more than 0.85 in females. It is again obesity. So it will be obesity again. Okay, that's great. Thank you to all of you. No issue, because I can understand that it is not given to you. It's not your fault, neither ours. But the coordinators, maybe because of some miscommunication, they couldn't get it. Belgaon is asking skin fold thickness of subscapular. No, it is the skin fold thickness when we add them together, all 4. Bicep, tricep, subscapular, suprascapular. So you add them together, and if it is more than 1 in males, more than 0.85 in females, it indicates obesity. So it's add all them together. I believe most of you must have been to good gyms, and in all those gyms they used to do it, because gyms, the instructors in good gyms, they follow very good criterias. Okay, now Now let us come to another very important portion, and that is on blindness. Now the third very important, communicable. ORS composition. Belgaum is asking about ORS composition. So I'm not sure why that must be told in your classes of pharmacology, but still, because every time you are saying ORS many time, ORS, I believe glucose is 75. This is, everybody remember it well. Then there is sodium 75, then there is chloride 65, then there is potassium, I believe 20, then there is citrate, I believe it is 10, and total 245. Yes, everybody is saying covered. It is covered. So Belgaum, please, it is covered, है ना? So 75, 65, 20, 10, 245, it is already there. So now let us get back to our discussion. We were on blindness. This class is over, dear. This ophthalmology class, if it is over or if it is yet to be there. Ophthalmology. What about your ophthalmology section? Bilaspur, it is covered. Okay, so that must be covered about WHO criteria and criteria of this national vector-borne disease, NPCB, National Program on Control of Blindness. Okay, then what we'll take is, we'll take that portion which she usually not cover, and I'll tell you what is that. When I write it, I believe you'll be able to get the idea, and that is on NPCB Vision 2020 model. And I know that that must be told to you that what are the diseases and what are the avoidable blindness problem, but make one only. Vision 2020 service delivery. Most common cause of ocular morbidity is refractive error, absolutely given by Agroha. Gorakhpur, it is refractive error, bache. It is refractive error, you should remember that only. Now let us come to Vision 2020. Vision 2020 service delivery. We are not going in detail of what actually the criteria are, because you already say that they are covered by your ophthalmologist. But let us say service delivery model. Service delivery model. So make again a triangle. Make again a triangle. Make a triangle. Rohtak is saying NPCB is not covered in ophtha. Yeah, I agree, but Vision 2020 is covered. Nah, so this is that service delivery which they don't cover, I cover it here. What do you make it is, you make a triangle, bacho, first. And in that triangle, make 1, 2, 3, 4. 4 rungs. Okay. And that only try to remember. There is one logic of remembering it. You should write here only this. Remember this only. 20,000. And in front, and on the left side of 20,000, write 50,000. 20,000, 50,000. So make this way. So it is 20,000, 50,000. Only remember this. Then there is a catch. What it is, I'll tell you. But first of all, make it as. Okay. This is 20,000 and here write 50,000. What you do is, you keep on taking 1 0 from here. So you make it. So what I request you is, just remember 20,000, which is written on the lowermost side of a triangle, and on the left side 50,000 is written. What you keep on doing is, remove 1 0 from here. So it becomes 2,000. It becomes 200. It becomes 20. Then on the left side, add 1 0. It is 50,000. Make 0 is added. It becomes 5 lakh. It becomes 50 lakh. It becomes 5 crore. And then student remember it with a mnemonic. They call it as CTSV. So make that mnemonic CTSV. So what is C? Stands for Center of Excellence. T stands for Training Center. S stands for service center. V stands for vision center. I believe now those who are going by their guides, they understand what is all about this entire diagram. It says that on 50,000 population, there would be one vision center. So by 2020, we'll be having 20,000 such centers. On 5 lakh population, we'll have one service center. So by 2020, we'll be having 2,000 such centers. On 50 lakh population, one training center will be made. So by 2020, we'll have 200 such centers. And on 5 crore, we'll have one center of excellence. So by 2020, we'll be having 20 such centers. So this is known as service delivery model of Vision 2020. And very many times it is asked in your entrance exam, where they do ask you regarding different criterias which are being used. So that was from this section of. Now again, I'll tell you few more things which are there in your entrance exam, and I believe it is not told by your respective teachers, and that is yes, that is again a very important question. I am trying to get to that. Yes, this is disability certificate. You know it very well that nowadays government is asking a lot about the criteria for disability or the disability, and you know that now we don't call these people who are disabled as disabled, but we call them as spatially abled. So for spatially abled people, or earlier we call as Rohtak, economic social blindness, that must be told to you by your ophthalmologist, dear. We are coming to different thing, visual disability. Rohtak, this is done by your ophthalmologist. Economic, social blindness. This is a topic which they usually take. Get back to your notes, bache. Visual disability first. Visual disability certificate. Visual disability certificate. Okay. Bilaspur, this visual disability certificate is done. Disability certificate. Because that is also asked in your entrance exam. No. Allahabadi saying no. Bilaspur is also saying no. I am writing that. First of all, it is given by government Ministry of Social Justice and Empowerment. Social Justice and Empowerment. Ministry of Social Justice and Empowerment gives Visual Disability Certificate. So what is Visual Disability Certificate? Rohtak, will get to that, okay, if time permits. But first of all, Visual Disability Certificate, let us do that. It is given by Ministry of Social Justice and Empowerment. I am writing here category number 1. On this, I am writing here better eye or corrected eye vision, better eye vision, or corrected eye vision, or vision in corrected eye, whatever. Okay. And here write percentage impairment. Those who have gone through their guides, there was once a question which was asked that if there is a single-eyed person, there is a single-eyed person, how much percentage of disability is given to that? So these are the kind of questions which are asked in entrance exam. So let us talk to that. If it is category 0, it means 6 by 9 to 6 by 18 is the better eye vision. Percentage impairment is 20%. Then category 1, 6 by 18 to 6 by 36, and it is 40%. Category 2, 6 by 40 to 4 by 60, it becomes 75%. Category 3, this was category 2, yes, and here they have written as, in category 2 also write field of vision, field of vision, 10 degree to 20 degree, 10 degree to 20 degree. So either this criteria is there, field of vision 10 degree to 20 degree, or 6 by 40 to 4 by 60, then percentage impairment is 75%. Category 3 is when we say 3 by 60, category 3 to 1 by 60, 3 by 60 to 1 by 60, or field of vision 10 degree, field of vision 10 degree. So if it is 3 by 60 to 1 by 60 or field of vision is 10 degree, then the certificate given is 100%. You may think that now the things are over because 100% disability is there, but no, category 4 also exists. What is category 4? I am writing here. Category 4 is finger counting at 1 foot to nil, finger counting at 1 foot to nil, or field of vision 10 degree. If finger counting at 1 foot to nil or field of vision 10 degree, then it is 100% disability. Because in category 3 also there was a 100% disability, bacho. Then last one is not a category, we should write here. This was the question, person with one eye. Person with one eye. Always remember, even if we take person with one eye and the other eye, better eye, we take as 6 by 6, then 30% disability is given to that person. So if you are saying that he or she is a single-eyed person, but the other eye is absolutely normal, 6 by 6 vision is there, then 30% is there. What they generally do sometimes in your entrance exam, they say that in one of the eye, vision is very less and other eye is not there. That means single-eyed person, but the better eye is having less than 6 by 6 vision. Then the disability should be more than 30%. I believe you will be able to understand, because 30% can only be given if it is having a perfect. We are not putting it in any category. That's why government has not put it in any category, beta. Agra, they call it as single-eyed person. Okay, so that was another criteria. Okay, so that was also done. So that was again, as I told you, because it's not told by your composition of PHC, CHC. Bhatinda is asking composition, or you are asking about that at what level you want to ask at norms for one PHC is there, at CHC is there. Okay, you are asking this. Okay, but we will discuss that later. Okay, so now we'll come to this beds in CHC, PHCs. You want CHC, PHCs thing first? You are asking this. Now tell me, you yourself is asking, is this corrected vision in better eye? Beaconit is asking. Yes, for this question it's very true that this is corrected eye, because we never look for the worse eye, because that's not required. That's not required. I'll tell you, because one of the confusion which was asked for by one of the student or one of the batch was that there was a confusion in low vision or economic vision. The only thing is, I'll get the answer, or that how you remember this thing well is, if I ask you legal blindness. Acha, Aligarh is saying, please stop here. What? You want rest? This lunch, Aligarh? The only thing is, okay, legal blindness. Legal blindness. Now tell me, this is your entrance exam question. India, and then last is word. So this is the question which give you most of you give the answers. That legal blindness in India is when we say that in India legal blindness is less than less than 6 by 60. And when we say legal blindness in word, it is less than 3 by 60. Okay, so always remember, in word it is less than 3 by 60. In India, it is less than 6 by 60. Okay, I'll stop after 5 minutes. Okay, and I'll ask or request the radiology sir that you've been given just 10 minutes before I leave you. So he will also start his class after 5 to 10 minutes. I request him, or I'll tell the coordinators. One thing is there, yes. So I believe now you can get the answer. This economic blindness means less than 6 by 60 to 3 by 60. And social blindness is less than 3 by 60 to 1 by 60. So I believe now you get the answer. One of the batch was saying less than 6 by 60 to less than 3 by 60, and social is less than 3 by 60 to 1 by 60. So that is the blindness which we were talking about. Vishakhapatnam is also asking, there are a lot of questions. Sir, is this the last PSM class? Yes, been allotted by the DAM's coordinators. They say it is the last class. Yes, suppose as I told you, that I'll request them if they can spare 2-3 hours for the question papers to get discussed, if they guess. Okay, low vision, as I told you, beta, low vision is as per NPCB. Or write this, because there are still some questions occurring on this. I don't know why these queries are being raised, because this question is done in ophthalmology, but still it is there. Don't worry, I'll write it for you, and then the things will be done. You write here WHO and you write here India, and here write better eye. If it is less than 6 by 18 to 6 by 60, it is low vision. Here also category 1 low vision. So category 1 low vision, 6 by 18, 6 by 60 low vision here. If we say category 2 low vision, it is less than 6 by 60 to 3 by 60. But unfortunately, India says economic blindness. Then category 3 blindness, and it is less than 3 by 60 to 1 by 60. Social blindness. Then category 4, less than 1 by 60 to perception of light. This is manifest. Last time it was. And then last. Category 5, no perception of light. Absolute blindness. So that is there. Okay, so if you look into this, now you can get the answer. Okay, 6 by 18, this is the problem. In India, low is less than 6 by 60, but in WHO it is till 3 by 60 it is low. Okay, so that is something which is there. And as now I am getting indications, so left that we need to cover by ourselves. Vilaspur, yes, there are no, as I told you, that the questions, most of the things are covered. We try to cover most of the things, but the things which are left are the small things, like for example HDI or PQLI, all these indicators, because they are there in the entrance exam, and they are also there in the discussion sheet. So what I tried was that they should be there only, so that was left. But still, if we didn't get time for if coordinators couldn't give us time in days to come, what I would like to tell you is some of the questions which are from the social medicine, because that is very important. So what I request you to do is, on your own, if suppose we don't get a chance to come again, to meet again, is social medicine. And in social medicine also there are only few things. We are just having 10 minutes, so we can discuss that also. Like for example, there are definitions, like they ask you what is an attitude. What is an attitude? What is a practice? These kind of questions. So suppose for example they say what is an attitude. So attitude is learned behavior. These are just definitions which you have to cram. Learned behavior, socially acquired, learned behavior, socially acquired, very difficult to change. Learned behavior, socially acquired, very difficult to change is known as attitude. Then they say practice. It is learned behavior, socially acquired, can change or can be changed with efforts. So attitude is learned behavior, socially acquired, very difficult to change. Practice, learned behavior, socially acquired, can be changed with efforts. Then you have questions like they call it as, they say what do you mean by customs? Customs. So it is set pattern of behavior. Set pattern of behavior which can be objectively verified. You remember these? In India, the women in rural areas, they cover their head in front of elder or elderly people. Then that is custom. Then there is, which we call as more stringent customs. Stringent customs are known as more, M-O-R-E, more. You remember that in Darbar Sahib or Gurudwara, which you normally call as, in Darbar Sahib you cannot enter without covering your head. That is something which is known as more. Just to cover your head in front of your elders is custom, but stringent custom is more. And when you make stringent more, it becomes taboo. Stringent more is taboo. Okay, so customs is there. More is very important. Ludhiana, I know dear, I'll request them, but time is always important. I never know whether they'll allow me or not. But yes, till then, we have, I'll try to discuss it with you. Definitely I'll try to discuss it with you, and I'll have a request to them. So taboo is stringent more. Okay, and then there are few more things which are asked. Like for example, they say opinion, goal, targets and objectives. Very easy to understand, Kolhapur. Objectives are, when they say objectives, you should say these are time bound activities which lead towards targets. So what you can remember is, no, Ludhiana, you will definitely get there. You'll definitely get. But let me first explain this question, which they say objectives. Objectives are where different objectives they add together and they lead to targets. You can get it this way. Different objectives, they lead to a target, and different targets lead to a goal. So goal is a dead end of all activities. You can say it is the topmost point where all activities meet. That is something which is known as goal. These objectives, these are time bound, and then they converted this. Okay, and then the last one is this. Yeah, Yes, Mumbai is asking again, sir, how many lectures were conducted previously? Was our first PSM? Oh, how can Mumbai, it's your first PSM lecture. Betaji, it is their last lecture. So that was there. That was a problem. It is the last lecture. Okay. Then there is one more thing which they were asking about, and that was acculturation. Dear, acculturation means cultural contact. Cultural contact is acculturation. So I believe you are getting answers to your question. Cultural contact. Cultural contact is acculturation or mixing of culture. And the best way of acculturation is when we say the best way of cultural acculturation is best way. Best way of acculturation is trade and commerce. Trade and commerce is the best way of acculturation. Okay, so I believe now it's the time for the second lecture. First of all, I will discuss it with the coordinators. Okay, so that we will also, as I told you, dear, these health indicators Bilaspur will be provided, and they'll be provided in a already printed manner. Health indicators, okay, but few health indicators we have also studied during our RCH classes and all. Theek? So good luck and best of luck to all of you, because it's the time for your second lecture. Second lecture is planned, schedule. So good luck, best of luck to all of you. Yes, I am on Facebook. Yes, you can catch me. You can try me there with the name of Pankaj Bharadwaj. Okay, so you can ask me Pankaj Bharadwaj, or you can tag somebody, you'll find it. Okay. Explanations also, sir. Ludhiana, I'll try to put the explanations, because though explanations are not there, but I'll try to get it. Okay. Bilaspur mail, try not to do the mails, because that's a really difficult thing. But yes, best of luck, good luck again. If there is anything, we'll discuss it on the Facebook. Bye bye, take rest. Bye and take rest. Bye bye. Bye. By lunch. Yes, it's a time for lunch. I understand, it's a time for lunch, dear. Bye bye.